Sure. I had the exact same thought.
2041. Everything is except 118 and 119.
Thank you.
I don't know if he's in the order approved.
I think we're mumbling, but Your Honor, we were just like on the record, kind of just calling tomorrow.
Okay, so we're back from lunch.
Yes, thank you.
You all are ready, so
We're having an ecumenical moment.
I'm so sorry.
We're having an ecumenical moment.
Well, I'm still just looking at our decorations over here.
I know that guy.
It's almost Halloween.
I'm assuming that is a demonstrative aid being used with Dr. Kirkpatrick.
Yeah, I didn't really expect that in the courtroom, to tell you the truth, Judge. I was wondering why you were smiling so much, and I turned around and realized it's because of our buddy here. I'm not going to use it with Dr. Kirkpatrick. Maybe we need to get it out of here so he's not tempted, okay? Because that could add an hour or two.
If we're not going to be using the skeleton,
He may want to use it.
It needs to leave.
I don't want to ask him to. I mean, let's get Herbert over there.
oh, so we've named the skeleton now? It's Herbert?
Yeah, it's not Herbert.
I thought it was Charles.
I'm sorry?
I thought it was Charles.
Charlie?
Whatever you want.
Herbie? Are we doing something that requires the white noise machine? Can-
Apologies again. Mr. Anderson, the lineup for tomorrow is who?
It was just sent over to Ms. Cross has it.
Okay.
So if you could just tell us who it is?
Sure. Depositions to be played of Dr. Napolitano, Dr. Perno, Dr. Vose. Depending on how ambitious the court is this evening, Dr. Newberger's deposition. We doubt that's going to happen. We understand. Dr. Corcoran, Joe Corcoran, will testify. Regina Camille, I don't know exactly how to pronounce her last name. It's Beata's sister from Chicago. And Jessica Blackrick, potentially the guardian ad litem in the underlying proceeding.
With respect to Dr. Newberger, I have an in-a-court meeting as soon as I leave here. So it's before I can even start, it's probably going to be 9:30 or 10 o'clock tonight.
We understand.
So-
Most likely Thursday.
Judge, I'm going to advise the court, having done the objections, there are a lot of them. And the answers are 5 pages long for each question. So it's not, I'm just advising the court, it's going to take it's a considerable time, I believe, of the court's energy to go through that deposition.
Yeah, I've already kind of looked at it.
Okay.
All I want to say is I remind the court that narrative response is to the form of the question.
Okay.
There's
Okay.
a lot of narrative response going
So
on.
questions.
Judge, the other, I don't know if something else needs to happen before this witness. If not, I wanted to raise the issue of the number of before and after witnesses that they are bringing. The sister who they want to testify live through Zoom, through the, I understand, interpreter, to my understanding would be just another before, what we would call before and after witness. They've already had at least 4. Suggesting that at some point it's a 94-3.
I'll be candid, the reason I'm calling her, she speaks Polish, and there's only a couple points I need to make, and primarily it is that without Beata around, it's becoming increasingly difficult for the children, and Jack for that matter, to stay in touch with Beata's side of the family. That and 1 or 2 other points, but it's not of the typical before and after. I'm sure she'll say she misses her sister, but that's not the point of the testimony. It is more simply about they all speak Polish primarily and mostly Polish. I'll leave it at that.
I continue to evaluate, but so far I haven't
Okay.
seen, at least with witnesses, that much cumulative. So. Anything else?
We have a couple Williams witnesses, Williams Rule witnesses on the Sally Smith thing. I was wondering if the court had glanced at it. We can take that up tomorrow. It only got filed at 7:30 last night.
See if it's docketed yet. Okay, yeah, it looks like it was docketed, so I'll take a look at it. But I haven't read it yet, so.
One of the matter, Judge, the matter of the audio recordings that plaintiffs wish to withdraw from evidence may come up with this witness. Certainly one of them, perhaps 2. Both of those recordings were made by Beata Kowalski, and we are prepared to show the court that an original video recording was made by Dr. Kirkpatrick, or acknowledged by Dr. Kirkpatrick, and the audio recordings should be usable. They go to a couple of points that we wish to make in his cross-examinations.
So, if it refresh my recollection here, the issue is that Dr. Kirkpatrick may not have given consent to 3 recordings that were admitted into evidence, and the defense is saying, at least with 2 of them, that there's circumstances that would suggest that either he did not have an expectation of privacy or he previously consented. Is that
Yes.
the issue?
Yes.
And how am I going to make this determination? What am I going to be looking for?
Well, you're going to look at Dr. Kirkpatrick's previous testimony and to communications that he's had with Mr. Whitney. The latter of which is what I'll start with. It's a communication from Dr. Kirkpatrick to Mr. Whitney that is timed here February 3rd-ish, 2020. Excuse me, Sunday, February 2nd, 2020 at 12:36 a.m. Attached to that communication is a summary, if you will, of follow-up evaluations of Maya Kowalski from Dr. Kirkpatrick, with an indication of what his records consist of. The initial evaluation was 9/23/15, and he lists a dictated initial evaluation, handwritten notes of the evaluation, a new patient information form reviewed with the patient and the mother, all of which are in his records, by the way, and then a pre-treatment video performed with pain thresholds recorded. And then there is a follow-up on following the 4-day ketamine infusion of 11/2, the infusion was the 7th, 8th, and 9th of October. The follow-up appointment following that, there was one on October 12th, and then there was another on November 2nd that will be the subject of questioning. Once again, Dr. Kirkpatrick gives a summary, an impression, recommendations, and then says the evaluation was documented on a video recording. Those are the two recordings that we wish to play the audio of, Your Honor. In addition to that, there was a deposition taken of Dr. Kirkpatrick, well, actually a couple of them, but I would tell the court that at least one of those depositions dated 3 February 2020, about the same time. I make reference in questioning him at page 73, line 15. Did you notice or chart any skin lesions? Yes. On the day in question on 9/23/15. Answer, I'm sorry, you said chart in my initial. I said chart, yes. Answer, no, I did not. But if you look at the video, there's some things you'll see in the video which weren't charted. So in other words, he's describing there that a video did in fact exist and that he took it. A similar exchange occurs on page 77 of the same deposition. In one answer, he says at page 11, line 11 of page 7, now you know why we do so many video recordings. There's such a huge amount of information, and by doing the video recording, we probably got into that during the video recording of the initial evaluation of the patient. So then, once again, he finishes the answer and refers me to the video. In a subsequent deposition on March 16th, 2022, at page 35, he makes reference, there's a long exchange that begins on page 34, carries over, but it culminates in an answer on page 35, line 19, with reference to his initial visit on September 23rd, 2015. He says, quote, by the way, all of this is documented on a video recording. And also she has weakness, she has asymmetrical severe dystonia. And then on page 37, I asked him, did you arrive at any opinion or conclusion regarding the cause for CRPS? And he answers yes, and that's documented on the video. I can go on with some others, Judge, but the point here is that he has indicated, oh, and I'm sorry, I should mention this. On page 40, there is a discussion of that same deposition. There's a discussion of video, and I asked him, did she have suicidal ideation? Answer, I'm trying to recall. That's, by the way, no. That I think at some point we did document that on video recording situation. That's with reference to his November 2nd, 2015 encounter with the patient, which is the subject of the other video audio recording that plaintiffs have asked to withdraw. There are several other references to the same matters, Judge, but that's the bottom line is that both of those encounters, September 23rd, 2015, November 2nd, 2015, both those encounters between Dr. Kirkpatrick and the Kowalskis were videoed by Dr. Kirkpatrick. Now, we are told those videos are no longer available. There's some controversy over whether and the extent to which he lost his chart at some point. But the point for present purposes is there isn't any question, based on multiple accounts by Dr. Kirkpatrick himself, that both of those visits were recorded by Dr. Kirkpatrick of his interactions with the Kowalskis. And as a result of that, he has no business being in a position to complain that he has an expectation of privacy with reference to an audio recording that Beata Kowalski supposedly did without his knowledge. Now, I say supposedly because those things were agreed to be put in evidence. And there's a declaration that's been signed by Dr. Kirkpatrick that I won't get into that now unless the court please, but there's some real question about the authenticity of that signature in our minds.
So, and I'm going to let you respond in a moment.
Thank you.
So your position is that the audio that Beata Kowalski made is concurrent to the videos that Dr. Kirkpatrick previously made that no longer exist, allegedly.
Correct.
Is that?
Yes, sir.
And so I guess the argument would be, since it's the exact same audio intercept, that there would not have been an expectation of privacy because Dr. Kirkpatrick himself was recording it at the exact same time.
Exactly. It's duplicative of what he himself was doing.
Dr. Kirkpatrick has been the subject of 4 depositions, 3 depositions, 2 depositions. He's been the subject of 5 subpoenas. The testimony that counsel just referenced was testimony in 2020, and it's non-specific to any particular date. When he says, by the way, all of this exists on videotape, he's referencing the fact that if you look at the videotapes that were done on October 5th, October 9th, October 12th, January 6th, and then a follow-up in May 28th of 2018, you can observe the dystonia. In that particular excerpt, he was being challenged on the existence of lesions. So he's referencing the body of videotapes that exist. Now, they have been hot on this issue for years, and he's been subject to repeated subpoenas to produce videos from these dates, which do not exist. The medical record after
Let me ask a dumb question.
Yes.
So we're talking about what specific date or dates of treatment?
The dates that they are interested in playing audio recordings from are September 23rd and November 2nd.
September 23rd, 2015?
Correct. And November 2nd, 2015. Those videos do not exist.
Has anyone asked Dr. Kirkpatrick under oath if he videoed either or both of those?
Never a direct question under oath in any of his depositions as to, was there a video taken on September 23rd, 2015? It's him responding that these symptoms exist on video.
Why don't we just ask him right now?
Great.
Judge is under oath saying they do exist.
Can you
I know what he's going to say now.
can you hand me a deposition that says
Sure can.
that he videoed September 23rd, 2015 or November 2nd, 2015?
Yes, sir, sure can. I'm handing your honor, first of all, the email, copy of the email.
I just want the deposition passage where there was a specific question as to those 2 dates. That's all I want to look at.
There's several dog-eared pages here, Judge. This is a deposition from, actually, I think this is both depositions. One from February 3rd, 2020, March 16th, 2022.
So there's a question. What page and line? What page and line am I supposed to look at?
See, the first one I believe is,
Okay, on page 73, there's a question. Did you notice, page 73, starting at line 15, did you notice or chart any skin lesion on the day in question, September 23, 2015? answer, no, I did not, but if you look at the video, there's something, so that seems to be a pretty a specific reference to that specific date.
He's referencing there, Your Honor, the videos that exist on dates near in time. Like I just mentioned, I think there's 5 or 6 videos that do it.
Let's just bring them in, ask them a couple questions so we can move on.
And a seminar on the on the November 2nd, Judge, if you look at page 40, on March 16th, he makes something close to the same reference. Page 40, lines 19 through 23.
And Mr. Hunter, you're going to ask the questions first of Dr. Kirkpatrick.
You just stand here, face the clerk, and raise your right hand.
Do you solemnly swear or affirm the testimony you're about to give will be the truth, the whole truth, and nothing but the truth?
I do.
All right, you gotta go on. Have a seat in that witness stand.
And you're Dr. Kirkpatrick?
I'm him.
Okay, sir, we're going to ask you a few questions about videos that
Okay.
were made, okay? Mr. Hunter's going to start.
Good afternoon, Dr. Patrick.
And you can have a seat, sir.
Oh, thank you. Thank you.
Did we swear the witness?
Yes, he's sworn.
Okay. Dr. Patrick, I'm going to ask you several questions about your medical records in general and your videos in particular. You do keep medical records regarding all your patients, correct?
Yes.
And you're required to do that by the Florida Board of Medicine?
I didn't hear that first word. What did you say?
You're required to do that by the Florida Board
Keep
of Medicine?
medical records? Yes, correct.
Okay. As part of your medical records, you frequently videotape your encounters with patients in order to record their objective findings, correct?
Sometimes, yes.
Okay. You don't do that routinely?
No.
So when you saw the Kowalskis on September 23rd, 2015, that was your first visit, correct?
Correct.
And on that occasion, did you videotape your objective findings in your encounter with the Kowalskis?
No.
You didn't videotape any part of it?
Correct.
Not even the pain thresholds?
Correct. Oh, no, nothing was video recorded.
Okay. Do you remember when I took your deposition, or Mr. Hughes took your deposition on February 3rd, 2020?
I don't, well, I had 2 depositions. I don't know which one you're referring to by
The
date.
first one?
The first one?
Yes, sir.
I remember that, yes.
Okay. Do you remember the following questions and answers? Did you notice or chart any skin lesions? Yes. Your answer was yes. On the day in question, on September 23rd, 2015. Answer, I'm sorry, you said chart in my initial question, chart, comma, yes. Answer, no, I did not. But if you look at the video, there's some things you'll see in the video that weren't charted. But go ahead. One was a skin lesion on the right side where she had most severe, and then I interrupted you apparently, or someone interrupted you. You didn't chart anything about skin lesions. No, I did not chart that. Now, why would you have said to look at the video for skin lesions if no video existed?
That was making reference to, which I do on all the patients that are about to undergo conscious sedation with ketamine. I video record their baseline function pain thresholds, so forth and so on. And on those occasions, not at the initial evaluation, but at the time just before the ketamine infusion, I do document those on a video recording. That is correct.
So in this particular case, when did you document on the Kowalskis?
In this particular case, the initial evaluation was on September 23rd, so approximately 2 weeks later, they came in for a pre-evaluation for the ketamine infusion, and on that occasion, a video recording was done documenting her function, pain thresholds, and so forth.
On October 6th, when you did the initial infusion?
I'd have to look at the date, but it's approximately 2 weeks after the initial evaluation.
Well, sir, we don't seem to have any record from your office of any further evaluation before the initial infusion on October 6th.
Objection. Misstates facts.
Do you have your records with you, sir?
Not here, no.
Okay. Let's move on to the next issue.
Let's talk about the November 2nd video.
Objection. Assumes there's a video. Object to predicate.
Well, let's get into that. Didn't you tell me in your deposition on March 16th of 2022 that this patient was having suicidal ideation?
I don't recall that conversation. You're talking about during my deposition, I said such a thing. If you
Yes.
want me to look at the deposition and
I'll be
try
happy
to
to
put
have
it,
you
put
look
it
at it
into
because
context, I'd be glad to do that.
my follow-up question about it is, your answer was, I'm trying to recall. That's, by the way, no, that I think at some point there we did document that on video recording the situation. That's your deposition. It's highlighted right there.
Right. I'm trying to figure out where that occurred in time. Let me think for a second here. I think where that was on a video recording was when she came back from Monterrey, Mexico, after being treated by Dr. Cantu, where there was a comment about she would rather. I think the comment. This is not a quote, but approximately what was said by the mother is that she'd rather go to Monterrey, Mexico, and get the ketamine infusion, and not wake up. Basically, that's not a quote, but I'm just saying basically, than to go on with life the way it was. That I don't think they used the word suicide in there,
Okay. Well,
or anybody did. I don't
Let
think.
me try to orient you this way, Doctor. The records we have suggested on November 2nd, 2015, after your series of infusions, but before the patient went to Mexico, you had a visit with these folks. And that's the subject of the question and answers that I just read to you and that you just read in your deposition. Does that refresh your recollection?
Well, you're trying to refresh my recollection about the dates. There was. I'm just trying to remember now. Let's see. There was a video before the ketamine infusion. Was during the ketamine infusion. There was one after the ketamine infusion. That would be number 4. No, number 3. And then after that, I think the next infusion. The next video that was done was when she came back from Monterrey, Mexico. I believe that's correct. I'm not absolutely certain, but I have records that I could answer that in a flash, but I don't have that with me right now.
Where are they?
Well, I think most of the records are on my computer, which isn't here right now.
Let me ask you this, Doctor. Did you videotape any portion of the November 2nd, 2015 encounter with the Kowalski family?
I'm trying to figure out what November 2nd, what was happening on that date.
It was a follow-up visit following your...
Does someone have his records from November 2nd that we can put up on the screen to refresh his recollection?
Sure. If we could publish.
I've got it right here.
Okay.
Well, Mr. Reyes can put it up.
No, 1055 is the exhibit number. 1055-0032.
Yes, that one. Is that in evidence?
Yes,
Yes.
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 Joint exhibit, yes.
Does this refresh your recollection, sir?
I'm reading it now. I believe, to the best of my recollection, that there was no video done on that date, Your Honor.
Thank you very much.
Can I have,
You can keep asking Mr. Hunter, but
Doctor, I'd like to show you a, to show you the text of an email exchange between yourself and certain members of the Anderson Gwynn firm. I'll direct your attention to your email that has the red arrow beside it with the see attached asterisk. For the record, what's the date of the email? The date of the email is February 2nd, 2020. 12:36 a.m.
Yeah, I see the attached, and I see the red arrow.
Okay. Did you look at the attachment?
Oh, it's in here? Okay.
You see the summary of follow-up evaluations of Maya Kowalski?
I see that listed, yes.
You see where you list in the initial evaluation of September 23rd, 2015, a pre-treatment video performed with pain thresholds recorded?
That's correct.
Did you in fact video a pre-treatment meeting with the family that day, September 23rd, 2015?
Not on that day.
With pain well, why does it say that there?
Because it was pre-treatment. I was just before I was to do the ketamine infusion the next day.
Ketamine infusion, sir, was not done until October 6th or 7th.
Looking for the date.
Why would it say pre-treatment video performed with pain thresholds recorded if no such video was done?
There was a video done pre-treatment, and that was the day before the ketamine infusion, I believe. I think that's correct, yes.
And so what date was that?
With the day before the ketamine infusion, it looks like you have here recorded on here, or I have recorded on here. Let's see, pre-treat, post-treatment evaluations.
You'd agree with me that paragraph reads, initial evaluation 9/23/15, dictated initial evaluation, handwritten notes of the evaluation, period, new patient information form reviewed with the patient and mother, period, pre-treatment video performed with pain thresholds recorded, all of which appears under the date of September 23rd, 2015. Correct?
I get your point, Counselor, but I think what I'm saying here is that that date was not for pre-treatment. That was 2 weeks later. So that video was done, that's referencing here, was done about 2 weeks later.
It doesn't say that, does it?
No, it doesn't say that. No, you're
So
correct.
you're telling Mr. Whitney here,
I'm going to butt in here. Dr. Kirkpatrick, apparently Beata Kowalski made some recordings of the appointments, or a portion of the appointments on September 23rd, 2015 and November 2nd, 2015. Did you know you were being recorded by Beata Kowalski?
Your Honor, you mean on the 23rd, 2015?
September 23rd, 2015.
No, there was no video, so there was no, as far as I know, there was no recording.
No, what I'm saying is apparently Beata Kowalski did make recordings. Were you aware you were being recorded? Did you consent to being recorded?
No.
How about the same questions for November 2nd, 2015? Were you aware she was recording you, and did you consent?
On that particular date, that was the date before the ketamine infusion.
No, it was 2 weeks afterwards.
Oh, 2 weeks after?
Excuse me, it was 20 days afterwards.
If there was the time I consent is when I do video recordings. So they're usually, when I do a video recording, there's consent involved. But if there's no video recording, there's no consent. Is that helpful?
And you maintain that position today?
Yes, sir.
Okay. Anything else you want to ask?
What percentage of your video, of your encounters with your patients are recorded?
Well, the ones that are recorded usually are before the treatment, so I can establish a baseline in terms of function and some of these objective measurements of pain thresholds and so forth. So
You post those on your website?
not always. No, because some might for educational purposes, but there's always consent. As for example, in the case of Maya Kowalski, she gave consent. The family gave consent for that to be posted.
But you wouldn't give consent to their recording you?
In my office, I've got HIPAA material around. I'm supposed to protect my office. And if somebody's recording and I don't know about it, that's an uncomfortable position for me to be in.
Anything else, Mr. Hunter?
Guess not.
Okay.
I just have one question for
No, you don't. Okay, the court's going to find, based on the totality of the evidence provided to me, that on September 23rd, 2015, and on November 2nd, 2015, that Dr. Patrick was unaware and did not consent to Beata Kowalski recording the audio portion of the discussion. Under Section 934.06 Florida statutes, those may not come into evidence. So I'm going to need to know what numbers of those two, and then we're going to have to remove them from evidence because Florida law does not allow those unconsented recordings to come into evidence.
Your Honor, those were previously admitted by our mistake as Joint Exhibit 1076 and 1077.
Okay, what we're going to do is we're going to remove those from evidence. They will remain marked for identification purposes so that they will travel with the file, assuming that there's an appeal at some point by one of the, or both sides.
I would like at some point, Your Honor, perhaps after this witness retires or before the break, to make a brief proffer, perhaps in the form of an oral representation regarding the content of those videos or audios.
I think we started this, was there any indication of consent on those? And I think the answer was no.
There was not, Your Honor, but what I want to do, there's a question regarding the veracity of what you've just heard, and I want to preserve the point for appeal.
Understood. Okay. But we're 25 minutes after we told the jury that we're going to start. Anything else before, or do you all want him to be sworn in front of the jury, or do you want me to just tell him that he's already been sworn?
I think it's fine to say he's already sworn.
It's fine.
Let's bring in the jury. Yes, sir.
All rise, jurors entering.
Okay, please be seated, everybody. Welcome back from lunch, members of the jury. I wanted to confirm while you're away, you did not discuss this case amongst yourselves, you did no investigation and received no information. Is that all correct? Correct. And that no one has approached you about this case, is that correct? Correct. And you have not seen any media accounts of this case, is that correct? Correct. Okay, and our next witness, please, Mr. Anderson.
Dr. Kowalski, Anthony Kowalski.
I'm sorry?
Kirkpatrick.
Okay, members of the jury, Dr. Kirkpatrick has already been sworn, so even though you have not seen him be sworn, I'm telling you he has been sworn. Well, I appreciate that.
Please state your name for the record
Anthony Kirkpatrick.
and where do you live?
My home address is 849.
need to skip your home address. Just
Yeah, we're on.
Okay, sorry. Hillsborough County, Tampa, Florida.
All right. And you are an anesthesiologist and pain expert.
Yes.
And how long have you been in practice?
It's over 40 years. Plus, I just don't know exactly, but it's at least 40 years. I've been practicing anesthesia.
And you were the physician who first diagnosed CRPS in Maya Kowalski.
Correct.
I'd like to give you to give the jury a brief summary of your background, training, and experience towards what you'll testify to here today, beginning with your undergrad, if you could.
Okay, I'll try. So I got my bachelor's degree from the University of San Francisco. From there, I went on to get a master's degree from the School of Medicine in Portland, Oregon. And perhaps I should clarify or explain what pharmacology is. It's not pharmacy. It's where you go in and you learn how to develop drugs in clinical settings. You teach in medical schools, which I've done. So that's pharmacology. So from there, I decided to go on and get a PhD degree in pharmacology, and that was from the State University of New York. From there, I began teaching. I actually went to Stanford for a while to do some research, and then I ended up teaching at the University of Nebraska, teaching pharmacology as a PhD. And then I went back and had an opportunity with the courses I had to get advanced placement at Ross University, which is located in Dominica. And there I took some courses, but the main part of my training took place at the University of Miami in the School of Medicine as a medical student. And I got my MD degree. And then while I was there, I was invited to give lectures in pharmacology to the anesthesiology residents, and from there the chief of the department suggested that I might want to do a residency in anesthesiology. I took him up on the offer. Now we're going back over 40 years ago, and so at that time the residency program was only 2 years. It was a very abbreviated type of residency compared to what it's now. While I was there, I began to develop an interest in the area of pain and how to control pain better as a resident in anesthesiology. From there, with my PhD degree and my MD degree, I accepted a position at the University of Illinois in Chicago. And in that capacity, I had an opportunity because of my PhD degree to do some clinical research, national multi-center studies all over the United States. I'm not going to go into the details, but on a drug which is still used today. It's called Esmolol. It's a drug. It's very rapidly acting. You can control the heart rate during surgery, that sort of thing. So I set up the studies for that nationwide. Worked directly with the FDA and all that sort of thing. In the meantime, I accepted a position as an assistant professor of anesthesiology at the University of Illinois in Chicago. And I continued my interest in pain there and got involved in, I'm not going to go into all the details, but some research on local anesthetics and so forth. But also while I was there, I developed an interest in pediatrics in anesthesia.
All right, tell us about that.
Okay, so we had one of the branch hospitals in Chicago focuses on ear, nose, and throat and eye surgeries. And they needed someone to kind of set that up so that one of the eye surgeons in particular wanted to be able to anesthetize, completely put to sleep under general anesthesia, children. And he didn't want them laying down like we normally lay kids down to do the general anesthesia. He wanted them to be vertical because the instruments he had to look into the eye for diagnostic purposes were not suitable. So I tried to figure out what kind of drug to use in those circumstances. Because when you go vertical, the blood in your head goes down to your legs more or less. And I needed a drug that would keep the pressure up. And of course, ketamine does that. It's the only general anesthetic we have which supports pressure. It's the only general anesthetic we have which supports breathing, so I wouldn't have to sit there and ventilate the patient.
Right, during the procedure.
Right, during the procedure. So I'd put the patient in my lap and teach the residents how to give general anesthesia while you got a child sitting in your lap. And so that technique was developed. I spent a lot of time there teaching residents in anesthesiology about dealing with the pediatric population. From
how'd you get okay, so we're there. How did you get involved in the actual pain management part that led to RSD Foundation?
Right. The way that I got involved is that I was interested in a local anesthetic that would last a long, long time. There was a doctor there in the Department of Pharmacology who was dealing with these little teeny microscopic capsules of anesthetic that, because it was encapsulated, would release the anesthetic very slowly. And so we went ahead and got a company started to develop that so that that could be used to give a longer acting local anesthetic. So that is where I got involved with the pain, because that was the target. That was the clinical application we wanted to use. And so from the university, if I can move on.
Yes, I wanted to ask you
Sure.
A few questions in the interim. I forgot. You've received certain awards in your career, have you not, for your medical service?
Yes.
You've received the Governor's Award from then Governor Bob Martinez for contributions to science and technology.
Correct.
1989. The Abbott Laboratory Award for excellence in chronic pain. Involved the Department of Anesthesiology, University of South Florida in 1990. Is that right?
Correct.
The Governor's Award for Leadership.
Your Honor, leading.
Well, it's faster.
For this purpose, I'm going to allow it overruled.
Governor's Award for Leadership at the University of South Florida College of Medicine, presented by Governor Jeb Bush in 2002. Is that correct?
Correct.
Right. And then a Dean's Award for Outstanding Service to the University of South Florida, presented by Dean Robert Doherty, MD, in 2002. Is that right?
Correct.
When you started out, was there board certification the way we know it now?
No, not at all.
So continue now. We want to get to the RSD Foundation and what you did starting with that.
Sure.
You can jump ahead to you and Dr. Schwartzman.
Oh yeah, right. So from Chicago, I went down to the University of South Florida School of Medicine. Took a position there in the Department of Anesthesiology. And it was during that time I was fascinated, really fascinated by this syndrome. We call it a syndrome. Complex regional pain syndrome. I was fascinated by it. And back then, most of these patients were accused of being crazy. Crazy. Because there isn't any like a laboratory test you could do to make a targeted diagnosis like diabetes and so forth and so on.
What year were we talking about, approximately?
That goes back to 1988.
Please continue.
Yes. And so I was fascinated by that, and I became friends with a Dr. Robert Schwartzman. He came to the university to give a talk, and we made. He is a neurologist, and I'm an anesthesiologist, and he.
I object to bolstering into the to authority of this without a foundation.
Why don't you ask more specific questions,
Yes.
Mr. Anderson?
Who is Dr. Schwartzman when it comes to the development of treatments for CRPS?
Judge, same objection. This is involved.
Overruled on that one.
Yes, Dr. Schwartzman is probably considered the most highly published individual in the field of complex regional pain syndrome. Back then, by the way, it was called RSD, reflex sympathetic dystrophy.
Is that still used?
No. We finally got people to stop using that, but no, it's not used anymore.
Is there more than one kind of CRPS?
Yeah, we divide it down into basically type 1 and type 2 complex regional pain syndrome. Type 1 means there's no major nerve injury, at least evident.
Right.
And type 2 is where you got a major nerve injury. You knocked out your brachial plexus, your sciatic nerve, something like that, would fall more into type 2.
What studies then did you and Dr. Schwartzman begin towards treatment of CRPS with ketamine? How did that work?
Well, it actually started with ketamine, actually, and that goes way back, way before 9/11. And we were trying to see if we could. There was some reason to believe it has this target the nerve pain. The pain is coming from within the nerves itself, as opposed to the type of pain you get when you injure yourself. Substances are released into your tissue, causing pain. When you get an ulcer that's inside your body, the same type of mechanism. It's not inside your nerves, it's substances released that trigger the nerve. And those are so the ketamine targets the nerve pain inside the nerve itself. Whereas these other mechanisms we talked about, the injury type and the type that you get with an ulcer, those types of pain processes are not very responsive to ketamine. To do that, you almost have to, you get pretty close to putting people under general anesthesia to really control the pain.
So tell us how the studies went. How did
Sure.
they develop?
Excuse me, I can very approach.
Let's move forward a little bit, and so we can get up to Maya Kowalski now. These results of the various studies that you performed, did it indicate that ketamine was useful in the treatment of CRPS?
Yes, in the beginning it was not doing what the patients call ketamine coma, being put under general anesthesia for 5 days. It was the low dose conscious sedation. The patient's awake, they can talk to you, but you're giving them ketamine. It's called conscious sedation.
So how did you discover this other procedure involving putting them under anesthesia?
One of the things we learned is that the benefits from the ketamine it's dose related. The higher you get the dose, the longer the response, the more vigorous the response. But there's a limit to how far you can go and still keep the patient conscious. There's going to come a point where you start to lose consciousness. And when that happens, the thing we concern ourselves with is protecting the airway, especially in children. Because children, when you give them ketamine, they tend to salivate a lot. So that saliva we all have is okay in your mouth, but it's got bacteria. It's not so okay if they get into your lungs. We call it aspiration into your lungs, and that can cause pneumonia. So remember, we're talking about conscious sedation. The patient can talk. They don't have a tube, an endotracheal tube, into their trachea to protect from the saliva going into their lungs, but they're awake. Your reflexes keep the saliva into your mouth. It's a protection we all have.
All right. So how did the intubation, general anesthesia, infusions work?
Sure. So to do a research study, you really need numbers. You really need numbers. While he had some patients there that were, now we're talking how we progressed it. I'm sorry, is that what your question? How we?
No, I wanted to get across to the jury whether it was effective or not. The procedure, once perfected, whether it worked.
Yeah, it worked. It worked in the vast majority of patients. Conscious sedation with ketamine works. It gets them controls their complex regional pain center. The vast majority of them.
Now, in the studies that you did regarding the general anesthesia, were you under a review board at that time?
Yes, all studies that are clinical in nature, you have to get it done by an institutional review board. And at that time, we decided that it would be done by Drexel University, where he was professor and chairman of the Department of Neurology.
I'm trying.
Sustained.
So, doctor, now, did you ever have to turn in to the institutional review board any bad results, for lack of a better term, out of this study using the anesthesia infusion?
Never had a.
Sustained. We need to move on, Mr. Anderson.
Yes, sir. All right. So, doctor, did you begin private practice in Tampa, St. Pete area, and when?
Oh, well, no, I've been based in Tampa.
Okay.
And so, no, my practice has been primarily in Tampa.
Okay. And so, when did you start treating patients in the Tampa Bay area?
That's when I arrived at the University of South Florida. That would put us at about 1988.
Right. And when did you stop actively treating patients as in an anesthesia practice?
Well, I'm still practicing.
Good. All right. So, how did it come about that you met Maya Kowalski?
Okay. From what I understand, the mother, Beata, had heard about me through her contacts. Her mother is a infusionist nurse, and she'd heard from some of the other patients about me, and that at that point in time there had not been a diagnosis, and the family really felt there was something desperately wrong with their child, and they needed another opinion, and they wanted to look at this possibility by consulting with me.
And was your first visit, I know you don't have your records in front of you, was your first visit on September 23rd, 2015 then?
Correct.
So tell the jury what you did on your first, the first visit.
Well, I have a policy, and that policy is that you always tell them how long the evaluation is going to take. Right. In a situation like this, it usually takes at least an hour to get through an evaluation. And I tell the patient the first thing I'm going to do is they fill out this we call the new patient information form, and I'm going to go, before I talk to them, I'm going to go over that material and see what I can get, sort of a background, what I'm going to be confronted with.
Now, doctor, when your new patients come in, are you like just trying to confirm that it's CRPS, or are you looking for whatever the diagnosis is, CRPS, or it could be something else?
Well, you have to do the latter. You have to look for everything, because that's part of making the diagnosis. You have to rule out all the other possibilities based on the history, based on the symptoms, based on the signs that you witness. You have to be able to rule out these other potential diagnoses, or at least you can come up with a differential diagnosis may include more than one thing wrong with the patient.
Do you then try to avoid what is known as confirmation bias? That is, everything that comes through the door is presumed to be CRPS until proven different?
Well, confirmation bias. No. Well, you have to fight that.
Right.
You have to fight it. You got to say, I'm here to help the patient. You can't help the patient if you're not can I use the phrase, an honest broker.
Got it.
Okay.
All right. So how did the examination of Maya go?
Well, she was in a lot of pain, and after a while working with children, you kind of learn of a way to communicate, to get them to relax and try to bring it down. At 10 years old, it's a challenge, but it can be done. You can try to get it down so they know that they're part of the discussion with the mother.
Right.
So we work work hard to do that. And I also invite the child to be part of the discussion. So the first thing we do is, most time when I look at the new patient information form, it's something like this, and it's incomplete. So I'll go through it and I'll fill in the blanks with them as we go through it.
How did Maya appear to you in terms of maturity and intelligence for being 9 or 10?
Remarkable. It's not just intelligent, it's curious. She wanted to know. She's listening to what her mother says. I wish we, you got a child that's a little unique, different.
Right.
Not a little, a whole lot different. So she's intellectually curious, very much engaged in the conversation.
So did she contribute then in going through and filling out, finishing the questionnaire?
Yeah, they both contributed to that process.
All right. So after that, what steps did you take to examine the child?
Well, I have a pretty much a head-to-toe type of examination, because remember what I said. You got to look for all the possibilities here, not just one thing that you've been doing research on. And so the first thing, like I say, I want to take a history. History is very, very important. I mean, the history is very important. So you're looking for, the whole history. Did it come from, how did this start? And then you go and work through all that process. And so you try to fit all that together and see if you can narrow it down a little bit what's going on. And then, of course, there is the examination that takes place. And there I have a pretty standard thing from head to toe. It doesn't just look at just the one area. And then another thing I do, and this is something that I'm very compulsive about, is I want to set things up and do things that leave me convinced that I've done a very objective evaluation.
And what does that involve?
Well, that involves fighting the tendency to want to be biased. I mean, we always want our patients to do well, right?
Right.
All right. So I try. One of the things I did since I started running the surgery center is I set up a new technology or a new methodology for measuring pain, not by numbers. You've heard this whole thing. Is it a 1? Is it a 2? Is it up to 10? 10 being the worst pain. That's for chronic pain. It's almost useless. For acute pain, it can be helpful. But for chronic pain, in terms of doing research, it's not very helpful. So I wanted to find a way so I could measure, without even talking to the patient, how much pain they're feeling between their earlobes.
And what did you use?
And what I used, I brought it today. I can show you if you want to see. It's a device called an algometer. And what it does, basically, first let me back up a little bit here. When you get CRPS and some other diseases, what happens as time progresses, maybe not initially, the body changes from being a local phenomenon, like you hurt your hand or whatever, sprained an ankle. It tends to progress into the central nervous system and into the whole body, the brain, everything gets involved. There's a word for it. I'm going to throw the word out and then forget it. Hyperesthesia. You'll find it in what they call the Budapest criteria. It's one of the things you're looking for when you do a diagnosis. Hyperesthesia.
All right.
And what that means is that all your senses, touch, sound, hearing, smell, they get accentuated so that you become very sensitive. So it was common for Maya to come in with dark glasses on because the bright lights were painful to her. But when she came in, the one thing that stood out more than anything else is her skin was exquisitely sensitive to light touch. Again, I don't want to use the big words for it, but I don't know what other people have said.
They've been well educated.
Have they? Because I don't know what other people have said so far, but it's called allodynia, okay? And it's like defined as any type of tactile stimulation, light touch, blowing on the skin, is perceived as being painful. She had that. She had a bad case of it.
What other symptoms or signs did you know?
Well, she had the allodynia. But the point I want to make is you can touch them and figure what this technique is called measuring pain thresholds allowed me to not only just detect it, but to quantitate the magnitude of it, of what she's feeling in her brain. And this device, by putting pressure on the skin, it gives you a number. It's called the pain threshold. So I tell the patient, look, I'm going to apply this device to your skin, and it'll feel like pressure. But I'm going to increase the pressure, and when the pressure turns to a pain signal, say stop. And we do it 3 times just for statistical reasons. 3 times we do that, and we get a number. And from that, and oh, by the way, one other thing is very important: they're blinded. I mean, they don't see the numbers. They don't see nothing.
Oh.
So this is what I mean by being objective. So if a child comes in, let's say, whatever, they want to stay out of school, so they're faking their pain, whatever, I can tell without even talking to the child if they are or not by doing this, the pain thresholds. It's a way to distinguish between what they're feeling in their brain in terms of pain signals as opposed to what's an emotional issue that might be evolving.
What, if any, other signs or symptoms were noteworthy during the initial evaluation?
The other thing that was noted, besides the generalized, the seeing problems and the touch, not just in her legs, but in her arms and so forth, measured with this device,
Right, but
was the dystonia.
okay.
Dystonia is when the muscles contract due to the disease. Usually they're curling in. Sometimes they'll actually stretch out, but mostly there's flexion. And it can happen in the hands or in the legs.
Yeah.
The interesting thing about it is, when it comes comparing adults with children, we rarely see it in adults, but we see a lot of it in children. So if a child comes in with dystonia, you got to be thinking about CRPS.
Anything else in terms of signs or symptoms? First from the examination, and then I'll ask you about the history.
Yeah, well, I think in terms of examination, of course, we try to measure temperature of the skin, and we're always comparing one side with the other. When the sympathetic, like I said, I have to go back a little basic. We knew from the very early, 30, 40 years ago, that this is a disease involving the sympathetic nervous system. And usually it's symmetrical on both sides. Your temperature is pretty much the same on both sides. But when you get the CRPS, things get disconnected so that one side may be cold, the other side may be hot. So I took out a device, which I brought today if anybody wants to see it. It's called infrared scanner. And I want objective information, so it measures down to 1/10 of a degree. So I measure for differences in temperature. Now, on this particular occasion, there was some difference, but it didn't reach my satisfaction for a significant difference from a medical standpoint. So I didn't record that there was a difference in temperature.
Okay.
Keep in mind that this is a disease that's labile. You come in one day and there's a difference. One side's warmer, one side's colder. If you think about it, there's going to come a point where they're kind of they're the same when they're fluctuating like that.
Any other signs or symptoms from the physical examination
That
you can think of?
From the physical, let's see. Yeah, there were. Yes, they're on the right side. Now, with this device, I'm able to tell you which side is worse. The algometer. I'm able to tell you which. Her right side was worse with the CRPS, the sensitivity, and she had lesions on that side, and they typically are like they look like little dots almost sometimes, but they sometimes will break up and then they actually become an ulcer where they breaks through the skin.
Right. Okay. And then very, very briefly, the history given, what was significant to you now that you had these physical signs?
Well, for me, there's some things that just glare at you. Hey, this is CRPS, complex regional pain syndrome.
Right.
The main thing is allodynia. There is nothing we know in medicine that causes this exquisite sensitivity to light touch than CRPS. There doesn't exist, okay? Doesn't exist. And so that just, right away, that became a very big deal. And of course, like I said, in children, the dystonia when they get CRPS is so common, that there. So putting it all together, the dystonia, which is a sign, and which means she couldn't walk. Right. She couldn't bear weight.
She was in a wheelchair?
And she was in a wheelchair. Okay. And she had the real sensitive skin, which you couldn't touch in certain areas, especially in her lower extremity, especially on the right side.
Let's jump ahead. So you made the diagnosis of CRPS.
Yes.
And you confirmed it with your testing?
Yes.
And so how did Beata present to you through this initial evaluation? The mom.
Well, it's kind of funny because I was talking about Maya being so intelligent and so inquisitive, and that's her mom. They have the same DNA.
Yeah.
You know, she's the same way. She wants to know details. She's very medically oriented, and I like that. And to me, it's refreshing to have a patient that gives you a little bit of a challenge. I enjoy that.
Did you find her determined or any other characteristics?
Well, she loved her child. I mean, she loved her child. And you know what? The child loved her mother.
That's always a good thing.
Yeah.
All right, so now you've made the diagnosis. What did you prescribe as the initial, strike that. Did you check to see what different therapies Maya had already been through?
I did, and I looked at particularly those places where she had the usual, customary treatments for CRPS. Physical therapy, maybe occupational therapy, and cognitive behavioral therapy. Those are the big things that you think about in the beginning. And I did think about those, and I did explain to them during the evaluation, our job is to get the legs moving. If we don't get those legs moving, especially what we're looking at right now, it could, well, she asked me what could it be, and I told her the truth. She could form blood clots in her legs, and they can break off, go to her lungs, and it could be fatal. And the problem with that, in children, especially in children, it's a silence. It's silent. It's hard to diagnose because in adults, when we get a pulmonary embolism in our lungs, you get chest pain, you get a feeling of apprehension, something ain't right. Kids, they just don't wake up in the morning. So that's one problem. The second problem is if they do get it, it's hard to treat. Why? Because remember what I said, they have the allodynia in their legs. Normally what we'll do is put them in pressure socks. Their skin is exquisitely sensitive to light touch. So that limits your treatment options in that situation.
So what type of therapy did you suggest or prescribe to start with?
I told her that if she can possibly get into some heated pull exercises, that would be recommended.
And did the Kowalskis follow your prescription, if you will, and find ways to heat up their pool?
Yeah, I understand they set up some kind of a solar system, yeah.
So how long did the warm water therapy last, the best of your knowledge, before they were asking you if there's anything else could be done?
Well, I think they came back and because I don't have the evaluation here in front of me, but they came back and she had a kind of an exacerbation of her symptoms, and then taking, and this is important, taking in consideration she's exhausted in moving forward with her symptoms and problems medically with the usual customary treatment, the physical therapy, the PT. And by the way, if they don't know what they're doing, PT can actually make you worse.
Right.
So they tried all those things. In fact, she spent a month, I think it's about a month, at Tampa General Hospital.
That's right.
I know their program because I was there for over 20 years. I think it's 20 years. I was there for over 20 years on the attending staff there.
Yeah.
And I know the program, and that's what it is. And so they've been through all that, the psychotherapy, all that, and she was just getting worse.
So what was the next step for a reasonably prudent physician,
right,
pain physician at this point?
Right. Having had the experience of doing those, over that 2-decade period, we've done a total of probably, let's see, we've probably done, well, be exact, 43 patients with the ketamine coma. I didn't think of that right away. That was not what I thought about. What I thought about was, let's try a low-dose conscious sedation where she's awake. Now, mind you, and this is I explained this to them because her mother asked me, you said, Dr. Kirkpatrick, that she will lose her memory temporarily, short-term memory. How long does it last? That's what I mean. That's the kind of mother she is, okay?
Right.
She's asking questions all the time. And it's temporary. But it's important that we give enough ketamine, because remember what I said. It's dose dependent. You have to get the dose up. So we want that temporary loss of memory.
Is that part of the resetting process?
Right, exactly. And so we don't want to get the dose so high for safety reasons that the secretions could end up down in the lungs. So the way we prevent that is they're always conscious. So they do not lose their long-term memory. Who's that over there? Well, what's her name? That's my mother. Or the mother is actually there in the room with the child. That's another thing we found very important. Children, it's really important kids to have the significant other there. If it's a mother, a father, there in the room. Because what happens sometimes, they start feeling the room's getting bigger, getting smaller, they get a little frightened. There's the mother over there. Dr. Kirkpatrick isn't trying to poison me. I know who that is. That's my mom. She's here to protect me. Because you do lose your sense of, but kids, we knew this for decades. Kids don't really hallucinate the way adults do. Adults can get really bad hallucination. We rarely see it in kids. Rarely. But nonetheless, the point is the mother's there. And we constantly ask them, what state do you live in? What country do you live in? So we always are communicating back and forth to make sure we don't overshoot.
I'm trying to move along.
Something responsive to a question here?
Yes, Doctor, we'll try to confine the answers a
Sure.
little more to the questions. I know you have a lot to say on this. How many different infusion sessions, if you recall, did Maya go through? The outpatient type, if you will.
Yeah, there were 4, and they were 4 hours each.
All right. And the dosing, do you remember what it titrated up to?
Yeah, I just happen to remember. It was about 135 milligrams per hour. Yeah, about that.
And what were the results?
The results, there was some evidence of improvement. But in the legs, which concerned me the most because of the possibility of pulmonary embolism, there was hardly any movement at all. That was my biggest concern. And I think the time is ticking, because a pulmonary embolism is something you can say, well, it's going to happen 3 days. It can happen at any moment. Any moment. And you got a crisis on your hands. Right. So that made some sense of urgency to the situation.
So how did you then respond if your outpatient infusions are not working? What was your suggestion?
My suggestion was that based on my experience of having done other kids with the high dose, the anesthetic dose of ketamine for 5 days, that would be something for them to consider carefully. And the way I wanted to make that happen is I put them in touch with some other children that we've done in Tampa. I mean, from our surgery center, and they've given permission to disclose their name. In fact, they posted their stuff up. But the point is, we had 2 kids that had gone down to Monterrey, Mexico, that had that done, and so I put them in contact. I said, don't make a decision, talk it over. I put you in contact with Dr. Cantu down there. Here's his phone number. I will send him all your records if this is something you want to do. And we do go through. This is not a research now. Keep that in mind. This is about treating Maya out because she needed some urgent care to protect her.
Let me ask you about your relationship with Dr. Cantu and his clinic there. Do you get referral fees or anything out of this?
No.
And do you do a I guess before they fly down there, do you do an examination to see if they're physically ready for that?
Yes.
And you get paid for that?
Yes.
So then they decided to do that, to go to Mexico?
Yeah, well,
where else is it offered, by the way, besides Mexico? Was there any place else?
No, to my knowledge, at that time.
Had it been offered in Germany before?
Well, Germany, as far as I know, it's so far away, and so Dr. Schwartzman and I decided to move in another direction.
Got it.
And the other thing about it is Dr. Cantu, again, I don't want to spend a lot of time on this, but he had a patient he wanted me to help with. I flew down there to help him with the patient. Put that patient under general anesthesia with ketamine for a week, and she did fantastic. And so with that, we decided to try to get Institutional Review Board approval to do patients in a study.
Dr. Kirkpatrick, I really need you to answer the question that's asked, and I know there's a lot of other information, but it's important that you only answer the question that's asked and not throw in additional commentary.
I understand.
I appreciate it, Mr.
time's, we're on limited time here. Okay, so, did you speak with the Kowalskis or otherwise find out how the ketamine infusion down in Mexico went after they returned?
Yes,
And how was it?
it's great. She started moving her arms, and she's had full function of her arms. She could take care of herself. She could comb her hair, brush her teeth, eat with her hands, and so forth.
All right. Now, was it necessary at this time do you terminate the ketamine infusions, the outpatient, or do you try to keep up with these, and if so, why?
Well, we have found over the years that sometimes these patients, after they have, not all of them, but some of them, after we do them, they have to have what they call it a booster. Okay? They come back. Remember what I said. It's the conscious sedation. They are awake when you do it.
Got it. So they need a booster.
A booster, yeah.
All right. What about after the booster? And they come back to the United States. In Maya's case, did she continue with ketamine infusions as necessary?
Yes, she did.
And who did you refer them to?
Dr. Hannah.
And why Dr. Hannah?
Well, we're a research center. Again, trying to keep this succinct as I can.
Okay.
Please. We're a research center, so most of my patients are coming in and they're paying out-of-pocket cash.
Okay.
And the reason for that is we can't do research unless we have money. And that money comes
Well,
from...
hang on. Let's
Okay, sure.
just stick with that. And so then why Dr. Hannah? Because you're a research center and you're not set up for...
For insurance.
Yeah, and for long-term infusion, I mean, to keep going steadily as necessary?
Right. And the other reason, I knew him well. He's my next-door neighbor across the bridge.
Okay.
I knew him. I've been to his facility. I know what he does. He's one of the most caring doctors I've ever met when it comes to patient care.
And so then, were you aware at this time that Maya had eventually had a port put in to facilitate the infusions?
Yes,
And do you know what hospital that was done at?
Johns Hopkins.
If I could show, publish in evidence 2041-036, I believe this is from Dr. Elliott, I think. Is this Elliott's? 036. You know what? I'll move on. You guys let me know. All right. So, Johns Hopkins actually put the port in.
Correct.
And through the course of 2016, did you ever receive a call back, leaving out eventually the October events, but did you ever get a call back from anybody at Johns Hopkins that was questioning or concerned about Maya having received the ketamine treatment?
No.
In Mexico or with Dr. Hannah?
No.
And to the best of your knowledge, how was Maya doing over the course of the spring and summer?
When she came back from Monterey?
Mm-hmm. Yes.
Yeah, she was, well, I did evaluate her when she came back.
Okay.
And she had full function of her upper extremities. I don't recall there being any...
Excuse me, Counsel, I'm sorry, can we get a date on that?
When
He's talking about evaluation he did, I'd like to know what date it was.
Oh, sure. Doctor, did you do an evaluation in 2016, or was this from accounts reported to you?
I did do evaluation. It was about 2 weeks after they came back, roughly.
Okay, all right. Okay, so through the course of this time then, nothing from Johns Hopkins. And then did you learn that Maya had had a relapse in the late, well, I guess it would be early fall, very late summer?
I think I did, and I don't know how I got it, the information, but it
You don't have the source of, you don't have the source of information here, this appears to be hearsay. He's testifying to third-hand information.
Madam Court Reporter, can I have the question back, please?
Question, okay, all right, okay, so through the course of this time then, nothing from Johns Hopkins, and then did you learn that Maya had had a relapse in the well, I guess it would be early fall, very late summer?
I
Overrule the objection. You can answer.
I can't recall that specific. The one thing, well, anyway, I don't recall something of that nature. I think there was, but I'm not absolutely sure about it.
Did it come to your attention that Maya was checked into Johns Hopkins All Children's Hospital in the fall of 2016?
Yeah, yes, I'm aware of that.
All right. And did there come a time that you had a conversation with one of the doctors there? Did you ever have a conversation with Dr. Smith?
Yes.
And tell the jury a little bit about how that came about.
Quick. The way it came about was that I had received a notice, and the notice was that they wanted medical records, and so I was wondering what that was all about.
Okay.
So I called. I found out it was Dr. Smith there at the hospital that was doing the investigation.
Okay.
So I called, and she wasn't immediately available. She called me back.
You have a conversation with her then?
Conversation, right. And I thought, this is going to be easy for me, because on my committee, I have a scientific advisory committee I'm the chairman of, and she's on my committee, Dr.
Objection, Your Honor. This is not responsive to the question.
I
Let's
think it is.
get the next question.
Right. Let's pull up then 2118-036. I believe it's partially redacted. It's a note from October 11th, 2016.
I don't believe 2118026 is in.
This is not it. That's not it.
It's not. It is. Put in this morning.
I thought it was 36, 37.
Yep, this is 36.
I thought you said 26. I'm sorry.
No problem. 2118-36.
Okay, my apologies.
We can publish that with the court's permission.
36.
Who called who, by the way?
I called her.
And through the course of this, then you had, I gather, a conversation about the Kowalskis.
Yes.
And what was your concern here, having received the request for medical records and knowing that Maya was over now at Johns Hopkins All Children's Hospital? What's your general concerns about this?
Well, the day before, I had sent a message to to Beata, the mother, and I hadn't heard a while from them, so I was curious what was going on. Then I get this note for records, and I'm going, because I want her to come to see me to reevaluate Maya, and then they're asking me for records, and I don't know what was going on. So I called and talked to Dr. Sally Smith, and she represented herself as being a part of the medical staff there at All Children's.
Excuse me. Objection, hearsay is called. The witness is editorializing about who she's associated with.
Party admission.
Well, I'm going to overrule that objection.
Let's look at what I'll represent to you as a personal note from Dr. Smith of October 11th, 2016, and ask you to review that, see if it refreshes your recollection as to the different topics that at least Dr. Smith took down here of recall. So what did you discuss?
Excuse me. Object, Your Honor. The witness said he doesn't have a recollection of this. He's being shown somebody else's record to comment on it or
Speaking
interpret.
objection.
Let's go to only legal bases. Do you recall the conversation?
Yeah.
So you don't need the notes to refresh your recollection?
I did a right after the conversation. I documented a memorandum.
That's not in evidence. We can't talk about this.
Okay,
So it'll just
all
be
right.
this.
Well, I can remember what's on the memorandum if that's helpful.
Well,
Okay. Then
why don't we take this down and
Right.
then you
I'll
just
just have
answer Mr. Anderson's specific question and only the specific question.
Yes. Tell the jury what you told Dr. Smith. First, I'm sorry. Did she ask you any questions before you told her things?
No, she didn't ask me anything.
What did you tell her?
I said,
Overall.
You can answer.
yeah, I was, I wondered what's going on. I understand you're with, Johns Hopkins, and tell me what's going on with the child and why I'm getting asked for records.
Did she give you a response?
Yes, and I can't remember the exact, words, but basically she was saying that there was a doctor over the weekend that saw the child and was concerned because when they lightly touched the skin of the child would jump, and that didn't make any sense to them. And they mentioned something about, that didn't make any sense. And it was not just in one area, it was pretty much both upper and lower extremities. And that didn't make any sense. And they were concerned that by the history that had been taken, that this might be some kind of a child abuse situation. And that really got me very concerned about the situation.
Before you tell us what you told her, in your experience, is it common or uncommon for doctors not familiar with CRPS to jump to a psychological conclusion before finishing their differential diagnosis?
Correct.
Legal basis.
Irrelevant, overbroad, vague, has nothing to do with the situation that we're addressing.
Overall, all of those.
Yes, it is, because this is a neurological disorder, and it has some signs and symptoms, and it carries with it a history. And if you don't know about that, it may seem a little bizarre. How is it that this child can have this sensitive skin all over?
So you'd seen this happen before, where?
Oh yeah.
And so to, I guess, to protect your patient, what did you tell Dr. Smith?
Well, when she suggested the Munchausen by proxy, and she did mention that, I said, well, with due respect, she has multiple objective findings that far exceed the criteria that we accept as a standard of care right now, the Budapest criteria, far exceeds those requirements.
So you told her about the
I said, it's absolutely clear. There's nothing, this is it. This is what you got. And I said...
So hang on, so you told her about the Budapest criteria? That was the standard?
Right, that was the standard of care.
Okay, and then...
Leading and argumentative, and need to have questions being responsively answered.
Well, I'm going to overrule the leading, and let's just make sure you answer only the question that's asked.
Yeah, I'll give you cues there. All right, so now I forgot where I was. I was asking, did you provide Dr. Smith with the criteria to use in evaluating CRPS?
I did. I pointed out my findings, yes.
Did you tell her how your findings met up with the Budapest criteria?
I did.
Did she say anything?
No.
What else did you tell her?
Well, I emphasized that the findings were objective, could be easily verified, assuming, stating that this is not something that's my opinion. It's really something that's documented, not just by me, but in the scientific literature. And
Jack Bolstrom.
Do you know what
Overall.
Do you know what Dr. Smith's specialty was? What kind of doctor she was?
Pediatrician.
And so, was that a concern to you that whether she had the training or ability to recognize this, or should she have been able to recognize it as a pediatrician?
We're talking recognize the CRPS.
Yes.
I don't think the average pediatrician would Well, no, I wouldn't say that. It's just that, I got the impression she just didn't really know hardly anything about what we were talking about.
Okay.
But I think most pediatricians, because this is the most painful disorder you find in kids, that they would know about it, and especially since the kids come in, as I said earlier, with a very unique picture in front of your face, the dystonia,
Your Honor, excuse me,
so forth.
we're editorializing beyond the scope of the question.
I thought that one was fair.
We're getting perilously close to opinions that this witness does not have the statutory competence to make.
Yeah, overrule that objection, but sir, I really need you to only answer Mr. Anderson's questions without adding on anything.
Okay,
It's really important.
I'll work on it.
Well, I need you to do more than that. I need you to do that because it's
Okay.
really important that you do that.
Sure.
Did you warn off Sally Smith from accusing this family of Munchausen by proxy?
Yes.
And did she respond to you with any particular questions about what these symptoms were or why you were warning her off?
No.
Did you tell her about the allodynia?
Yes.
Did you tell her about the dystonia?
Yes.
Did you tell her about temperature changes?
Yes.
Did you tell her about the, and I'm not sure you documented this, the sweating or any other symptoms and signs that you had noted?
I don't remember those in particular, but the ones that I had documented, I did reference those to her.
All right. And so after, how long was this conversation?
I would estimate maybe 30 minutes, something like that, approximately.
And did you explain to her about generalized neural sensitivity?
Yes. Oh, yes.
And so after all of this, again, any response from Dr. Smith of an inquisitive nature about what the distinction was between Munchausen by proxy and CRPS?
No.
Now, in follow-up to this, did you have any more communication with either Dr. Smith or the hospital about this situation? The situation being Maya Kowalski in the hospital and a diagnosis of Munchausen by proxy as to the mother.
No.
The embolism you spoke about before. Did Beata Kowalski question you about this, I don't want to call it phenomenon, but this circumstance that this embolism was a danger potentially to Maya?
Yeah, she did query me on that.
And did she continue to follow up about this?
Yes.
What did you tell her? Strike it. What did she tell you about her concerns over improper care of her daughter?
I think her concern was her.
Hearsay and standard of care.
Overruling the standard of care, I think I'm going to sustain the hearsay nature of that question, though.
3 or 4? 803, 3 or 4? With the...
I don't think you've got a foundation for that question for that exception.
Did you still consider Maya Kowalski under your care?
Yes.
And were you attempting throughout this period to keep yourself apprised of Maya's medical condition?
Yes.
Did
Objective foundation, Your Honor. The record will reflect this witness had last seen the patient 10 months ago.
Okay. Let's, again, no speaking objections, so let's not do that.
I'll be happy to approach.
I don't need an approach on this one. I'm overruling it. You can continue.
And from time to time, did Beata Kowalski provide you with updates on how Maya was doing over the course of the spring and summer of 2016?
Yes, sir.
Did she continue to use you as a source of information about Maya's progress and symptoms and treatments?
Yes.
So, at this point, when Beata called you in the fall of 2016? Was it for the purposes of updating you about Maya's care and her concerns?
Objection, Your Honor. He's asking for the state of mind of another.
Sustain that question.
What, if anything, was the purpose for that last call in the fall of 2016 between you and Beata Kowalski?
Same objection.
Overruled that one.
I'm not sure what date you're talking about here.
Did you have, during the fall of 2016, did you have any conversations with Beata Kowalski where the topic of this embolism starting in the legs was addressed?
Well, that conversation was before then, but yeah, she brought it up. She mentioned that her legs aren't moving. What is she going to get clots down there?
And to the best of your knowledge, did she participate in various, strike that, with this disease, were there chat rooms and websites where CRPS patients and their child, parent, could go to exchange information about the disease?
Yes.
And to the best of your knowledge, based on what she told you and your own knowledge, did Beata Kowalski participate in those from time to time to learn about CRPS?
Yes.
Objection, hearsay foundation. Overruled.
So, in this conversation then, did Beata ask you any questions about what would happen to her daughter if she continued to have care that was inappropriate to treating her CRPS?
Objection, Your Honor. May we approach?
Yes. Objections overruled. Any other questions, Mr. Anderson?
What was Beata Kowalski's concern expressed to you in this conversation?
About blood clots forming in her feet, in her legs.
What happens if those go untreated?
I think I mentioned that it's a silent pulmonary embolism, goes to the lung, and could be fatal.
Did you tell Beata Kowalski this in that conversation?
Numerous times when she asked. And the other part of it, Counselor, is that I emphasized that if she doesn't get the ketamine, it's going to be a slow, painful death.
No further questions.
Members of the jury, we're going to take a hopefully no more than 10-minute break. Let's try to keep it to 10 minutes. Do not discuss this case amongst yourselves. Do not do an investigation and receive no information. All rise. juries out of our presence. Two things. I should have done it when we came back from lunch. Just to remind everybody in the audience, unless you are a member of the credentialed media or an attorney, no one is allowed to use cell phones. So please listen to the court deputies on that issue. Second, and remind the attorneys that if you wish to have a private conversation, you need to push the mute button
Yes.
on your microphones. With that, let's take a 10-minute break, and we'll be back in 10 minutes.
All rise. This was a recess.
Seated, everybody. Any issues before we bring the jury in?
None for plaintiff.
Don't believe so, Your Honor.
That's that'd be cool. Leave. Why don't you grab them? I'll be okay.
All rise, Drew is entering.
Okay, please be seated, everybody. Members of the jury, just want to confirm while you're on break, you did not discuss this case amongst yourselves, you did not do any investigation, and received no information. Is that all correct? Correct. Did not talk to anybody about this case or receive any information or anyone approach you. Is that correct?
Correct.
And did not see any media snippets or anything like that. Okay. Mr. Hunter.
Good afternoon, sir.
Good afternoon.
Let's see, you described for the jury earlier your background and training. You're not board certified?
No,
You're not board certified in either anesthesiology or pediatrics?
correct.
You've never been board certified in anything?
Correct.
You weren't telling the jury that there wasn't a board certification when you went through residency, were you?
No, I didn't say that.
Okay. There was, correct?
There was.
But you're not board certified, never have been?
Correct.
Okay. You don't have any hospital privileges at this time?
Correct.
Haven't had any in a number of years, correct?
Correct.
And your clinic, institution, is on East Bush Boulevard in Tampa?
Correct.
It's out near Busch Gardens?
Yes.
You have not done any specific research with respect to the pediatric population, have you?
Specific, just only pediatrics? Is
Yes,
that your
sir.
question?
Yes, sir.
No, I have not.
And you're aware that ketamine is not known to be safe or effective in pediatric patients below the age of 16?
I don't think that's correct.
Doesn't the manufacturer admonish you that the safety and effectiveness in pediatric patients below the age of 16 has not been established?
Oh, sir, if you ask the question that way, yes, I agree. I agree with you.
Okay. Let's talk about the first time that you saw the Kowalskis. By the way, where are your medical records?
I think they're on my computer. They are on my computer.
Where would that be?
On my laptop. It's right now. It's back at the hotel.
So you came here today to testify about this case before this jury without your medical records?
I was told that they had that what's in evidence is my records,
Okay.
my medical records.
Okay, so we'll work off that. The records we have suggest the first time you saw these people was September 23rd, 2015. Is that right?
Yes,
And before that date, you'd had no communication with them, right?
correct.
And you knew that they had seen a number of other physicians, correct?
Yes,
Okay. And you described for counsel the examination you conducted. You knew from the mother that there was thought to be a psychogenic component to the patient's pain. Is that right?
by history, correct.
Okay. And you knew that the patient had been seen at Tampa General Hospital?
Yes,
You indicated you were familiar with the program there.
Yes.
Know the doctors involved with it?
That I'm not so sure of. I'm not so sure.
Well,
In fact, I'd have to say probably not. I remember looking at those records, and I don't think I remember recognize any of those names.
well, you didn't see the Tampa General records before you did your examination and diagnosis on September 23rd, did you?
Probably not. No.
As a matter of fact, you told the mother you didn't want to see them. Is that right?
No, that's not correct.
It's not correct?
No, it's not correct.
Okay, we'll get back to that in a second. But in any event, you didn't speak with any of the doctors at Tampa General, did you?
No.
And you knew that the patient had been seen at Lurie Children's Hospital, correct?
Correct.
You knew Lurie's was a pediatric hospital?
Correct.
You never spoke with any of the physicians there, did you?
Correct.
And did you ever speak with a Dr. Wyndham regarding the patient's immunodeficiency status?
I don't recall that.
Well, you were told that the patient had a selective immunodeficiency, weren't you?
Yes.
But did you talk to the allergist or the immunologist who diagnosed it?
I don't recall that.
Did you talk to Dr. Kreisman at any point?
No.
Did you talk to Dr. Wassenauer, the patient's general practitioner?
I don't think so.
Okay. Were you aware at the time that you made the diagnosis of CRPS in this patient that this patient had seen over 36 other physicians about her pain and condition?
I don't know the exact number.
You knew it was a good many, didn't you?
Yes, sir.
Did you talk to any one of them?
Well, I don't remember the list. I mean, so I don't recall that. I don't recall talking.
You had a patient in front of you who dozens, literally dozens of other doctors had seen and treated at length. And you were the first one making a diagnosis of CRPS, correct?
Correct.
You're the Lone Ranger. You're the first one that came up with that.
Correct.
Did you call any one of those doctors and attempt to reconcile your diagnosis with all the other diagnoses that had been made regarding this patient?
No.
Incidentally, you were the first one to diagnose CRPS
Yes, sir.
on September 23rd, 2015.
Yes, sir.
How do you suppose it was that the mother thought that was the current diagnosis a week before, on September 16th, 2015?
Before she saw me on the 23rd of September?
Yes, sir.
I'm not aware of that.
Well, could we put up Joint Exhibit 2012, 25 and 26, please? Yes. Joint Exhibit. My copy says Joint Exhibit at the bottom.
The 2000 series is not joint.
I beg your pardon. I said 2000, 1000. This is 1012-0025. I beg your pardon. Sorry. I'm not sure whether that's 2000, 1012. Okay, well, if you look at the end of the second paragraph on that page, up one, reflex sympathetic dystrophy is the most current diagnosis.
What's the date on that, counselor?
The date on this is September 16th, 2015. It's part of the
September.
records of Dr. Kreisman. Have any idea where Dr. Kreisman would have gotten that history other than from the mother?
Where's the date on this document,
If
counselor?
you go to the first page of it,
please.
1012.25, you can do it side by side. You look, date of visit, September 16th, 2015.
Somebody's blocking my, I'm trying to read this and they're blocking my view.
Beg your pardon.
Thank you.
Date of visit,
I'm just trying to see how I'm just trying to read the document. So this is page 2. Or what page is it? No, I'm sorry. Page 26 to 28. If we have time, I'd like to read this.
You go back to the first page, please. Can you make it larger, just the first page?
Yeah, thank you. That would be helpful. Yep.
well, it's a pulmonary note, doctor, so I'm not trying to belabor what the pulmonologist's findings were, although I want to ask you whether you ever talked to him.
Mr. Hunter,
I'm sorry.
you wanted to look at the document to answer your
Okay,
prior
that's
question.
fine.
Yeah. Can we scroll up a little bit, please? Thank you. Okay, scroll up a little bit more, please. More, please.
You want the next page?
Well, it's.
Or you want the top of page 1?
I want to. I'm reading it. So go down. So I'm looking at page 25 of 28. Can I see that whole page? I'm seeing part of it here. I'm still seeing part of it here. I don't see the whole.
So
The
then you
rest
need
of
to go
it.
to the next page.
The next page, please. So this will be the next page. Am I correct on that?
You are correct.
Thank you, sir. Oh, here we go. Okay, this is what I was looking for. So the sentence reads, there is a concern from the mother that the child has selective immunodeficiency. And then the next sentence reads, reflex sympathy is the most current diagnosis.
Right.
So, but it's not, he's making the diagnosis. He's just saying that that's what, I don't know. I don't understand it. It doesn't make any sense. There's nothing to back up what he's saying. So I don't know.
Okay. But point is, you wouldn't know where he would have gotten that history the week before you made the diagnosis.
I don't know where it came from, sir.
All right. Now, as a result of your visit on the 23rd of September, you recommended that this patient undergo your ketamine infusion therapy 4 days in a row, correct?
Can we bring up that record so I can see what you're referencing? I mean, there's more to it than just what you just said. I'd like to see what you're making reference to. Could you bring it up so I can see it, please?
What record do you want me to bring up, sir?
You're saying I went from this to that.
No, what I'm saying is, what I'm asking you is, as a result of your visit with this patient on September 23rd, 2015, in which you diagnosed CRPS, did you make a recommendation that the patient undergo ketamine infusion therapy?
There may have been some other things included. That's my point. And I'd like to see
Okay.
what else it says.
In that case, if you would bring up the doctor's September 23rd treatment note, which is Joint Exhibit 1056-001.
May we go down on the document, please? Scroll up. Thank
If you
you.
go over to page 2, we can talk about the recommendations you made
Okay.
at the bottom.
Okay.
You've told us that you...
Well, wait. I want to read it. Can you bring it up so I can read it?
Sure.
I want to see what I said. Okay. So what it says, sir, it doesn't talk about that right. It talks about some physical activity, some heated pool exercises. That's the way it started.
Okay, I suppose I was gonna back up and ask you. You told council that you wanted her to try heated pool exercises.
Correct.
And then you wanted the patient to be evaluated by a pediatric internist to determine if there's anything you can do to minimize the risk if you should elect to go forward with the four-day ketamine infusion, correct?
Correct.
Okay. Who was the pediatrician that you had clear her for that ketamine infusion therapy?
Anthony Kreisman.
You spoke with Dr. Kreisman?
No.
Did you ever see a report from Dr. Kreisman about that?
No.
How do you know he cleared her then?
Because I told the mother to go over the material, the question, the basic question, is there anything else that he can do to minimize her risk for the procedure since she has a history of cough asthma?
Okay.
And that was the only question I wanted to know, that if there was anything that could be done to further reduce the risk.
Tell me when you heard from Dr. Kreisman that was the case.
Well, the first time I heard it was from the mother when she came back for an office visit with the child.
So the mother told you that she had gone back to see Dr. Kreisman and to discuss that with him.
Correct.
When did you have her seen by a psychologist?
I did not do that as far as I can recall.
Isn't that something you usually do with patients that you refer to Dr. Cantu?
No.
Isn't that on your website as something that you usually do with patients that you send to Dr. Cantu?
No.
Now, ultimately, you did go forward with the ketamine infusions, right?
Yes. Now, sir, be clear. You're talking now about the conscious sedation, or now you moving over to the ketamine coma procedure? Where are you now?
No,
When
I'm
you asked me
talking about what you did.
What I did. Okay, no, that's
And
fine.
you never did a ketamine coma, did you?
I've done it, but I've done it before, sure.
But you didn't do it on her, did you?
No, I did not.
You did that in Mexico, correct?
Correct, and I've done it at Tampa General Hospital.
Okay, and you don't do it there anymore, do you?
Correct.
You're not a member of the medical staff there and haven't been for about 10 years, correct?
I'm not sure it's 10 years, but I haven't been there in a while.
Okay. And they haven't been doing that in a while, have they?
No, I don't think so.
Okay. When you talk to your patients about this ketamine infusion, I'm going to call it ketamine infusion therapy. Okay? Is that
Okay.
right?
Can we say conscious versus general anesthetic?
Okay. I'll
please?
call it conscious sedation therapy.
Thank you.
Okay. And incidentally, you want the patient conscious to avoid risk to the patient's airway, correct?
Correct.
Okay. And if you were giving high doses, anesthetic doses, you would want the patient to be intubated to protect her airway, correct?
If the patient was being anesthetized in general anesthesia, yes. Otherwise, don't give me the dose thing, because the dose, some patients require the different doses. You have to tailor the dose to the patient's needs.
We're going to come back to that. Let's talk about the warnings, the information that you give your patients before ketamine infusion conscious sedation. Okay?
Okay.
You tell them, and we can bring up his consent form if you wish. Joint Exhibit 1056, 0158, and 0159. I'm going to cut to 0159 and ask whether you tell your patients, told the Kowalskis you didn't know if the therapy with IV ketamine will help alleviate the symptoms of CRPS in every patient long term.
Correct.
And you basically tell them in the next paragraph that the more you treat patients with IV ketamine, the more you'll learn about it, correct?
Correct.
And then you warn them that they might have problems from it, correct?
Correct.
And those include infections, correct?
Correct.
Gastrointestinal imbalance,
Where are you reading, sir? I'm looking at the document here. Are you?
I'm reading the third bullet point up from the bottom of the page. Gastrointestinal imbalance and/or discomfort and muscle weakness due to ketamine.
Yes.
And then you warn them about loss of weight.
Yes.
And over on the next page, you've talked to us about this, you've warned them about temporary loss of memory.
Yes, and is this the next page now we're looking at?
Yes.
Thank you.
Okay. So, with all that, these folks elected to proceed, correct?
Yes, with conscious sedation. Correct.
Okay. Now, I want to make sure I understand how much you gave them. And I'd ask that Joint Exhibit 1055, 008, and 009 be put up. If you can put those up side by side and highlight the total ketamine at the bottom of this page. That indicates you gave a total of 137 milligrams?
It's what it says, yes.
Is that correct?
Yes.
And then if we go to the next page, next infusion, which was the next day, 1055, 0012, 011, and 13, we see that you gave 215 milligrams that day, correct?
I don't see anything here, sir.
Oh, I'm faster than my guy, sorry.
I'm looking for the
If you
total.
look at the bottom of 2013, if you'll scroll up some, Clay, on the right-hand side, I thought. So in 2012, I'm sorry, you got 2013, excuse me, 11, I beg your pardon. You've got Joint Exhibit 1055-13, it should be 1055-12. Is that correct?
I see it now, yes, sir. I don't see the date, but I see the number.
Okay. Then if we switch to 10-8, and we go to Joint Exhibit 1055-14 and 15, we see that the total ketamine given on the third day is 255, correct?
I see that, yes, sir.
And then on the fourth day, 10-9, October 9th, we look at 1055, 17, and 18, we see that the last dosage was 300 milligrams, correct?
Yes.
Now, you consider those as high a dose as you wanted to give this patient, correct?
Yes.
And she stayed conscious during this, correct?
Yes.
And you charged the family a total of $10,000 for the 4 days of the treatment?
Yes. Well, plus the follow-up. We don't charge them for coming back and being reevaluated and repeating all the measurements that we did on them, including the videos and so forth. Follow-up, strength and range of motion, pain thresholds and so forth. That's all included. Everything's included. It's not just
Okay.
the 4 day.
So you did an assessment of the patient after that on October 13th?
Correct. That would be probably the following week.
And you said at that point that she showed improved post-treatment pain threshold associated with slight improvement in strength and range of motion, especially in the upper extremities.
I don't see that report here, but
I'll be
what you're
happy-
saying sounds reasonable, but I mean, if you
Okay.
want, I can confirm that for you.
I'll put it up. It's Joint Exhibit 1055-22. So, would you have done a video this day?
Let me think. Okay, so the answer is probably yes.
Okay. But in any event, the improvement was slight, and the patient was still wheelchair bound,
Yes,
still couldn't walk,
yes,
still had allodynia,
yes,
still had dystonia,
yes,
still had limitation of motion,
yes.
really didn't have any functional improvement, correct?
Well, the way I worded it was just slight. We have a video recording of this, and if I recall correctly, I believe I commented on the video that there was some slight improvement. I believe I'm sorry, best I can recollect, in the foot on the left side.
Okay. So, the records we have suggest that you next saw the patient on September 2nd. Excuse me, I'm sorry. I beg your pardon. November 2nd of 2015. That sound correct? And I'll ask that Joint Exhibit 1055-32 be put up for the doctor's benefit.
Okay.
Now, when she came in this day, it was billed as a return patient evaluation, correct?
Yes.
And when she's in your office that day, she's complaining of increasing CRPS pain in her legs, correct?
Correct.
And she was unable to intake adequate fluids and food.
Correct.
She appeared dehydrated.
Correct.
And with that dehydration, even with that dehydration, you were unable to carry out blood pressure monitoring secondary to pain, even with a manual cuff, correct?
Correct.
So you said you noted that she had a reasonable peripheral pulse for a 10-year-old, but you weren't able to assess her blood pressure, correct?
Well, there is a statement, reasonable peripheral pulses for a 10-year-old. For a child that age, she had a blood pressure. I mean, she didn't have, sometimes you see enough kids, you just know that if you were able to get a blood pressure, you were going to get a reasonable blood pressure out of that.
It's always good to have a blood pressure. I think we can agree on that.
Well, I wouldn't go, I wouldn't say that. If you got a patient talking to you, I don't get blood pressures on that necessarily.
But she's dehydrated.
Yeah.
And you can't get the blood pressure.
She had it says
You
peripheral.
you were concerned about the dehydration, weren't you?
Yeah.
And as a matter of fact, both the mother and the child were expressing to you suicidal ideations, correct?
I don't see this in this report.
Well, didn't you testify to that?
I don't think so. As on this date? No, I don't recall that.
We'll work on that for a minute. Before we go to that, can we agree that at this point you thought this child's CRPS, which you had, and incidentally, didn't you rate this child's CRPS disability as severe on your first visit?
I believe so. Yes, but to factually state that, I would like to see my report, but I'm almost sure that I did. Just thinking about it.
In this report, you indicated that the CRPS she had was intractable, correct?
Correct.
And it had proven refractory to your first care, correct?
Yeah, very poor response.
Okay. And so let's talk about the problems that the patients were encountering. And I'll refer you to page 142 of your deposition.
I'll trade you. This is yours.
Oh, okay. Thank you.
I'm sorry, which page, sir, would you like me to go to?
Well, I was going to go to page 142.
142.
Where you testified as follows. I asked you, but she was able to be touched during the previous infusions. A, yeah, before, yeah. This patient has deteriorated in this situation to the point it's a life-threatening situation, both from a physical standpoint, hemodynamic standpoint, and from the standpoint of emotionally suicidal. And you could not get vital signs that day. Is that correct?
No, that's not what. Did you take any vital signs on that date, doctor? Answer: well, I tried. I mean, remember, I said I couldn't get a blood pressure cuff on her, and we just read here where I was able to get our normal pulses on her.
Okay, but the complete set of vital signs includes blood pressure, right?
Yes, it would.
And your
yes.
history indicated that she was unable to take fluids, correct?
Yes.
So she's dehydrated, and you have no way to rule out that that's not going to get worse, correct? If she's not taking fluids.
Well, if you read the rest of this, it talks about getting an IV, getting IV access established, okay? And that was the idea. Get an IV in, because the problem is that, I'm trying to remember, this is, yeah, I think this was the time we thought that, talking to the mother and so forth, that it would be a good idea to have IV access. I think at this point, if I remember correctly, they were thinking about going to, let's say I don't know. I don't remember exactly the context of this.
Well, that's what I was going to ask you about. Because you didn't make a referral to an emergency room that day, did you?
No.
And you didn't make a referral to a psychologist that day, did you?
No.
And you didn't really do anything to give her fluids, did you? You yourself, did you give her fluids?
No. We talked about starting an IV on her.
You also started talking about placing a PICC line, correct?
I can't remember if that was the day we had that discussion or not.
Okay. Well, was that the day that you wrote her a prescription for a PICC line?
It's possible. Again, I have to check the dates of this report, but it's possible that was something that I thought would be a good idea. And
okay, well, let me ask.
I'm trying to put this in the total perspective of what was going on at the time, in terms of the mother contacting Dr. Cantu and there's a lot of moving parts here,
okay. And
I'm trying to put it all together in my head as we're sitting here.
Incidentally, well, I'm going to ask Clay to put up 1056-211, but let me ask you a question. You've indicated a couple of times concern about pulmonary embolus, correct?
Correct.
Isn't dehydration a risk for pulmonary embolus?
Yeah, I suppose you could argue that, but that's a stretch. That's a stretch.
If you put up 211, you've written a prescription here for a patient with poor IV access requiring chronic treatment of CRPS with IV ketamine requires a 2-lumen line placement for immediate fluid replacement. Is that right?
Yes, sir.
And then you wrote her a script for IV to be administered by the mother, correct?
Sir, do you mind putting that up, please?
I will find it in just a moment, do exactly that.
Thank you.
How about 1056-212?
Got it. Okay, thank you.
Patient currently dehydrated with poor nutrition requires fluid with normal saline, 500 milliliters now QD PRN. In other words, each day as needed, correct?
Yes.
Something electrolyte, something weekly. Check electrolytes weekly, is that
Yes.
right?
Yes, sir.
So you envision the mother giving this IV to the daughter herself, correct?
If I believe that is correct, she's an infusionist. That's correct. I believe so. Again, I'm trying to recall the details here.
And then subsequently, there was concern about the patient's level of pain, correct?
I don't know. What are you referring to?
Well, I'm having reference to a prescription that you appear to have written, put up, can I show you that? I'm going to have to show you that because I'm not sure this is in evidence. Is 304301 in evidence?
Can we see it? Yeah, is that in evidence? Maybe approaching this.
for a second.
Just come on, Judge, I'm sorry. Dr. Kirkpatrick, you then, after this, wound up referring this patient down to Dr. Cantu, as you've described?
Yes.
And at that point, she came back to you for a follow-up visit, correct?
Yes.
And you saw her in January of that year, is that right?
I believe so, yes.
Okay. Now, you then have told us you lateraled the ball, if you will, to Dr. Hannah?
Yes.
And I saw no notation in your note that you kept up with her after that. Is that true?
I'm just trying to reflect on that. I don't recall her coming in for an office visit. That was the reason why I had wrote a note the day before Sally Smith. I called Sally Smith.
Okay.
And so I hadn't seen her in a while, so I wanted her to come in and see how she's doing.
Okay. And the reason you wanted her to come in and see how she was doing was that when you heard about Dr. Smith, you had not seen this patient since January, correct?
No, that's not the sequence, Counselor. The sequence is not knowing anything about any problems with Johns Hopkins, without any knowledge of any of that. I just thought, well, listen, I haven't seen this child in a while. She's, 9 months or so, or maybe less than that. And I thought it would be a good idea to have her back. So I wrote an email to the mother saying, how is she?
I understand. You did that in October of 2016, correct?
Yeah, before I knew anything about Johns Hopkins, just because I was
understand.
interested in seeing how she's doing. Yeah.
I understand that. You did that before you knew anything about Johns Hopkins. You'd written an email to the mother to ask her to come in, correct?
Yeah, I wanted to evaluate the child.
And then you hadn't seen the child by the time you spoke with Dr. Smith, correct?
Correct, other than when she came back from Monterey, yes.
Okay.
That's correct.
So, excuse me, can I help you also?
Sorry.
So the point is that when you talked to Dr. Smith, you had not seen or evaluated this child since January of 2016 when you saw her after she came back from Monterey, correct?
Correct.
Okay. And you hadn't spoken to Dr. Barr about his treatment of her, correct?
I believe, was he the hyperbaric person? I'm trying to remember the names.
No, Dr. Spiegel was a hyperbaric.
Was it? Okay.
Had you spoken with him?
No, I haven't.
And you knew nothing about hyperbaric therapy, did you?
It's kind of vague in my mind. I don't think so.
And you didn't recommend it, did you?
No.
And you never prescribed any further ketamine for the patient in 2016 after January, did you?
No, she was being seen by Dr. Hannah.
Dr. Hannah. So you may have had some emails with Mom about the patient, but you hadn't had any contact with her between October and January, correct?
I don't recall.
Did you ever speak with Dr. Hanna and learn from him that his treatment of the patient had failed?
No, I never heard that.
When you saw, did you ever see the patient in October 2016?
I couldn't. She was taken, well, I don't say taken. She was admitted to the hospital.
Between October of 2016
What date?
and October 7th, 2016.
Okay.
Between that date and January 1st of 2006, January 6th of 2016, you never saw this patient, correct?
Correct.
All right. Now, if I ask you to assume that as of October 7th, this child was in a wheelchair, could not walk, had pain, allodynia in her lower extremities, had dystonia, was not in school, and was basically in that level of functioning, would I be describing the child as you saw her on September the 23rd, 2015?
No,
Why?
because, as you noted, she had seen, Dr. Anthony Kreisman had seen her before she went to Monterey, saw her afterward, and said, this child is totally different. No pain.
No, sir. I'm not asking about when Dr. Kreisman saw her.
No, I'm talking about what was being reported, her care under Dr. Hanna. I think that was the question.
That, sir. What I asked you was this. If you assume for the sake of my question that her condition was as I described it on October 7th, 2016, my question was, would she be in essentially the same condition as she was when you saw her, not Dr. Kreisman, when you saw her on September 23rd, 2015?
Based on the information that I have available, she was doing a heck of a lot better.
In what respect?
Well, you read the reports from people that saw her during that time frame.
No, sir. I'm not asking about what happened during the time frame. We'll stipulate that there were ups and downs. What I'm asking you is that in net effect, from September 23rd, 2015 to October 7th, 2016, was there any net change in this child's condition?
From the time I initially saw her, let me see here, get your question right. From the time I first saw her on September 23rd, you're asking me what now? I'm trying to understand your question.
My question is, when you saw her on September 23rd, 2015,
First visit.
She had dystonia, correct?
Yes.
She's wheelchair bound.
Yes.
She can't walk. She's non-weight bearing.
Yes.
She doesn't have good function and movement in her upper extremities.
Yes.
She's not in school.
Yes.
She can't take care of her own activities of daily living, correct?
Well, that I don't know if I agree with.
Everything else we agree on, right?
Well, I don't know. You're asking me to lump a whole bunch of stuff together.
Well, I'm asking you what your examination revealed, sir.
Mr. Hunter, you gotta let him answer.
Isn't that what you found in your examination of that patient on September 23rd, 2015?
I saw the patient. Again, I'm trying to get the time frame in my head. You're saying from the way she was, her function was when I saw her initially, compared with what?
Compared with October 7th, 2016.
October 2nd.
7th.
That's the day she had a relapse. Ended up in the morning at Johns Hopkins.
It's the day, several days after her relapse, and she did wind up at the hospital that morning. I'm describing to you her presentation to the hospital versus her presentation to you on September 23rd, 2015.
Okay, I think I got it. Okay, so she has a relapse and ends up at Johns Hopkins with a stomach ache and a recent injury to her foot, and looks like she's got an exacerbation of her CRPS. If that's your question, I would say she was in worse shape than when she entered the hospital. She was having a crisis. She was having acute injuries to her abdomen, acute injury to her foot. That's not what I saw when I saw her.
Go ahead, I'm sorry.
And that's not what I said. So that particular occasion, when she was being admitted, she was worse off when she was being admitted because of some events that took place suddenly. And that happens to be the stomach ache, the injured foot, acute injury to the foot, as well as having her CRPS probably exacerbated by the acute injury she was having, which includes the stomach ache and the injured foot.
What acute injury to her stomach did she have?
Well, she had she complained of stomach ache. From what I understand from the hospital records that I read, she came in a kind of a fetal position. And
did you review the entire hospital record?
Yes.
Mr. Hunter, you gotta let him finish his answer.
Yes, sir.
Were you finished with the prior question?
Well, I hope I answered the question. She, at that moment in time when she was admitted, she was in worse shape than was when I first saw her on September 23rd, 2015.
You talked about telling Sally Smith about Munchausen by proxy, correct?
When you say telling her about,
well, let me rephrase the question. That was a bad question. You talked about warning her not to pursue that, correct?
I did.
But you weren't surprised that she brought that up, were you?
In the beginning of the conversation, yes, I was surprised.
Didn't you warn Mr. and Mrs. Kowalski that they might be suspected of Munchausen by proxy the first time you met with them on September 23rd, 2015?
I don't recall that.
You're not saying you didn't, you just don't recall, right?
I don't recall.
And if I understand correctly, you did send this mother an email in the early hospitalization of her daughter, correct?
Yes.
And you did tell her in that email, and incidentally, this is after she knew that there was an investigation going on, correct?
The mother?
Yeah.
Yeah, okay. Let's yes, I don't know. Yes, I would assume so, yes.
Well, you knew she was very upset.
Yes.
And you told her at that time that if your treatment wasn't adopted, her daughter would die a slow and painful death within reasonable medical certainty.
Would you like me to look at the entire communication I had with her at that time?
I would be happy to show you the email that you sent her at that time.
Thank you.
I can only but find it.
Can we see? We need to approach her.
Doctor, I think we're moving to another topic at this point.
Go ahead, move your own. Nothing further this time, Your Honor.
Mr. Anderson.
I'd like to publish 2698. For the record, this is mine on August 11th, 2016.
First off, is this in evidence?
It is in evidence.
Okay.
2698. And Doctor, I'd ask you to review this. I'll have questions after. This is August of 2016. I think that's probably enough. Doctor, the child you saw, September 23rd, 2015, could that child that you saw then do all that she could do in August of 2016? Move that freely, appear that devoid of pain, move with that joy when you saw her in September?
Not that joy, especially. She was not very joyful the day I saw her back in September.
And between that and October 7th, did Maya go into a fairly severe relapse where much of the progress over the intervening spring and summer was lost, at least for a while?
I'm sorry, would you please repeat the question, please?
Sure.
Thank you.
You don't object
What-
to the question, Judge, you don't specify the time frame when.
During the child, strike it. Are you aware that in September of 2016, Maya had a severe relapse of symptoms of CRPS? First,
Well, this was just before.
before the October 7th admission.
Right. Well, yeah, I was aware of it just before, correct.
And was that the reason why she looked like she did when you first saw her?
Well, at the time of admission?
Yes.
On October 7th?
Yes.
Yeah, she looked worse. She was in crisis, yeah.
But immediately before that relapse, the child looking like she did in the last exhibit, was that progress, significant progress?
Oh, of course, she's a whole new human being, yeah.
As to the who diagnosed first, was it your understanding that she saw or heard from her own patient, Dr. Daniels, that his daughter had RSD, and maybe Beata should check that out?
Objection, relevance, and hearsay.
Overruled.
You can answer.
Oh, I heard something about that, and I don't know, yes, I heard something along those lines, yeah.
When Beata Kowalski came to you, had she already been told there was a possibility of
Yes.
RSD?
Yes.
So this is not about diagnosing her. This is simply about whether she knew the phrase RSD.
Correct.
Overruled.
That's all, Your Honor. Oh, yeah. Thanks. You mentioned Dr. Kreisman at Johns Hopkins. Recall Dr. Kreisman?
Yes.
And you recalled something about him seeing Maya after she came back from the trip to Mexico? Recall
Yes.
that, Doctor? And then can we publish 1024 and specifically 1827?
What is it?
I'm sorry. No, that's not right. It's 1024-0030.
Same question.
It's Dr. Kreisman's note from the.
It's the pulmonary. Doctor, will you take a look at this and see if...
Object, Your Honor, can we approach?
Let's take it down. You may continue, Mr. Anderson.
Doctor, please read the first full paragraph there. Actually, the second one under physical examination.
It's the read to yourself. We're just not reading documents to the jury.
Second paragraph, physical exam. Okay, got it.
Please read that. Is that what you were referring to when you were talking about the impression of this Johns Hopkins All Children's Hospital doctor of Maya once she had come back from Mexico?
Yes.
Anything else?
That's it, Your Honor.
Okay, let's take the record down. Any follow-up, Mr. Hunter?
No, sir.
Members of the jury. You know what I'm going to do. Make sure you give Debbie Cooley all of the notes. Did we get all of them? We're still working on notes or questions, I should say. Has everyone finished with their questions? Okay. Do not discuss this case amongst yourselves. Do not do the investigation. Receive no information.
All rise for executive.
We'll reflect that Dr. Kirkpatrick is now out of our presence. The jury's out of our presence. Let's go through the questions as quickly as we can. Page 1, red number 1 in upper left. In simplest terms, is it safe to say, unlike an understood and highly researched illness that has an almost flowchart list of symptoms that lead to a diagnosis and treatment, is CRPS still being researched and therefore needs a certain amount of, quote, latitude, end quote, in both its symptoms diagnosis and its treatment to be allowed? And the next question, prefaced with a simple yes or no, will do. It really does, right there.
He's looking for your job, Judge.
The designation of, quote, board certified, end quote, was brought up. Is board certified a designation that a doctor knows more or is better than a non-board certified doctor? Next page on the same question. You received a formal request from Dr. Sally Smith of JHatch for your records about Maya. Is that correct? You stated you made a call to Sally Smith. Did you send the copies to Smith? So here is this juror's questions. Any objection to any of those questions?
Board certified is kind of a complex issue, Judge. I don't think it's an unfair question, but I think it would be confusing to try to explain it. I'm fine.
I'm looking for objections or no objections.
No objection as to the first two. I guess I got an objection to the three of them. You guys?
Feel good.
So the defense has no objection to any of these questions. Is there any objection from the plaintiffs?
Is that all the questions?
Well, that's from this juror.
Yeah. No objection.
Okay, so both sides agree all these questions can be asked. Next one, red number 2. Did you review Maya's medical record before treating her? If not, why? Here is that one. So no objection from the defense.
No objection.
No objection from... You're going to love this question, defense. Does Sally Smith work at JHatch? Is she still there?
is calling for a legal conclusion.
Well, she is still there as a staff physician, as she always was. But I think we got to do it.
I have two objections. You'll have an agreement on something. I will agree with all of you.
You want to write that down?
October 10th, 4:11 p.m. Okay. Red number 4. During Maya's infusion, you monitored her vital signs during the ketamine infusions. Were they within normal range for a child her age for all of the infusions given?
No objection.
And the last sheet has multiple questions and subparts. In it is Juror 181. Okay. What relation or role does CRPS play in diagnostic issues? The next question, if actually answers number 1, you skip number 2. But number 2 would have been, does obstination have a direct connection to CRPS? Please describe the relation. Question 3, how many treatments had Maya undergone before you recommended ketamine coma? Number 4, was Maya's treatment a success, failure, or both? Question 4A, if success/both, if she entered JHATCH, isn't that actually a failure? Question 4B, if failure, how would additional treatments with ketamine be different? Question 5, can confirmation bias also apply to hearing from a patient's spouse/family member without considering all the current data sets? Here is that page.
I don't understand what obstination is.
Obstipation, what he's trying to say, constipation.
Oh,
Is it constipation?
Yeah, obstipation is constipation on steroids, so to speak.
I'm just trying to read the handwriting.
You don't have to take this.
Get Dr. Kirkpatrick, please.
May I counsel if I tell,
To just answer the questions?
yeah, I'll tell him, but I was gonna let Dr. Hannon.
Oh, yeah, you can let Dr. Hannon go. I think they went together. Discuss this case amongst yourselves. You did no investigation and you received no information. Is that all correct? Correct. And you saw no media accounts of this case. Is that correct? Correct. And you were not approached by anyone about this case. And as you see, the doctor was outside our presence, just so you don't have to take my word for it. Okay, Dr. Kirkpatrick, there is a series of questions from the jury. And again, I want you to just answer the specific question and only that question. Okay. The first question. In simplest terms, is it safe to say, unlike an understood and highly researched illness that has almost a flow chart list of symptoms that lead to a diagnosis and treatment, is CRPS still being researched and therefore needs a certain amount of, quote, latitude, end quote, in both its symptoms, diagnoses, and its treatment to be allowed?
I'm trying to get my arms around that question a little better. Can you help me, Your Honor?
Well, I think perhaps the lawyers, I think, understand and will ask that question a little bit different way. So let me go to the next question.
Okay.
And the jury said a simple no or yes will do. The designation of, quote, board certified, end quote, was brought up. Is board certified a designation that a doctor knows more, or is it better than a non-board certified doctor?
Well, that's a very good question, and that's been looked at in terms of claims, malpractice claims and all that sort of thing. You really can't tell them apart, So, you have to remember, though, my situation is one where I trained in anesthesiology over 40 years ago, and it's totally different now in terms of the residency requirements and so forth and so on. And the reason I maintain my academic status all the time, including right now, still academically working, is the PhD degree, because that's what you do, and if you have that skill, you're marketable in the academic field, especially in pharmacology.
Okay.
I hope that answers the question.
Okay, Dr. Kirkpatrick, let's just, the next question I think calls for a yes or no. So
Okay.
hopefully we can confine ourselves to a yes or no on this. You received a formal request from Dr. Sally Smith of Johns Hopkins All Children's Hospital for your records about Maya. Is that correct?
From her personally, no.
You stated you made a call to Dr. Sally Smith. Did you send the copies of the records to Dr. Smith?
No.
Did you review Maya's medical records before treating her?
Yes.
Okay. And members of the jury, again, if I'm not calling out the question that you sent, that means I can't ask that question. Next question. During Maya's infusions, you monitored her vital signs during the ketamine infusions. Were they within normal range for a child her age?
Yes.
Was that for all of the infusions given?
Yes.
What relation or role does CRPS play in let me read it again. What relation or role does CRPS play in digestive issues?
What we know and what my experience dictates is that it does affect the GI tract. And the CRPS affects the sympathetic nervous system, which we say goes into the GI tract, innervates the GI tract. And it shouldn't surprise you that you can really end up with poor function of the GI tract, which includes constipation. And I've seen that many times in patients. And guess what? Ketamine helps that. It helps it big time.
The next question is, does obstination have a direct connection to CRPS? And if so, describe the relationship.
I'm not sure. Other than what I just said about the sympathetic nervous system and its relationship to CRPS, I don't know what else I could add to that.
Okay. How many treatments had Maya undergone before you recommended the ketamine coma?
By me personally, is that the question?
Yes.
Okay. For me, it was the 4 ketamine infusions, not to mention my prescriptions, to aggressively involve her in heated pool exercises. I found over the decades that is the most important thing. And if I may, Your Honor, because it's too dangerous. When you have the kind of legs she had, you can re-injure yourself and set off the CRPS again. So lack of having buoyancy when you're in the water is very protective of avoiding a relapse.
Okay. Mr. Anderson, do you have any follow-up questions?
May I speak to counsel about responding to one?
Yes. Please do. Mr. Hunter,
Mr. Young, I'm sorry. No questions.
members of the jury, do you have any follow-up questions? Did I say hand? Okay. May this witness be excused, or does he need to remain under subpoena?
He may be excused from plan.
Remain under subpoena.
Okay. So what that means is it's possible you might have to be called back, but you are free to go today. So thank you very much for being here.
Okay, thank you.
Judge,
Oops. Oh,
Yeah.
I apologize. You can hang there. Members of the jury, that is going to conclude our testimony for today. So I'm going to let you go. Do not discuss this case amongst yourselves. Do not do any investigation and receive no information. And we will see you tomorrow. Deputy Coley, if you could have them ready to go at 9 a.m. Same bat time, same bat channel.
All rise, jurors exit.
Okay, please be seated. Doctor, there's going to be a few more questions, but we had to do these outside the presence of the jury. So before I let you go, I think Mr. Hunter has a few more questions for you. Mr. Hunter, you have the floor.
thank you, sir. I just have 3 areas of question, Dr. Kirkpatrick. May I approach the witness, Judge?
I'm sorry?
May I approach the witness?
Yes.
I'm showing you page 1 of Defense Exhibit 3043. It's dated November 5th, 2015. What I'd like to ask you is whether the signature at the bottom of the prescription for hydromorphone PCA 0.02 milligrams per milliliter, no basal rate, demand dose 0.05 mg, lockout 30 minutes, supply bags for 60 days, may titrate dose and lockout interval to max demand dose of 1.1 milligram, 0.1, I'm sorry, milligram with lockout of 20 minutes based on patient response. Is that your signature on the prescription?
No,
That prescription is not yours?
it is not my prescription. I didn't write this down at the bottom of the page. Patient is terminally ill.
I understand that. I'm not asking that. I'm not asking whether that is yours. I'll get to that.
Okay.
What I'm asking is the
Yes.
prescription here.
That's there. Yeah.
Is the signature on the script itself, not what's below it, but
Yeah.
on the script itself, is
Sure.
that yours?
Yes, sir.
Okay. And you've told us before that the notation patient is terminally ill and whatever that is below that is not you.
Correct.
Okay. Then, but to be clear, the prescription itself for the hydromorphone PCA device was written by you.
Yeah, but the thing is, it wasn't executed.
Leaving that aside, that was you wrote the
Right.
script.
So the script is not valid. But anyway, yes,
But you wrote the script.
I wrote the script, but the script never got executed.
In other words, it got filled.
Never. Well, right.
Okay. That you know of.
Excuse me.
That you know of.
Yes, that's correct. As I know it. Yes.
Okay. All right. So I'm also going to hand you Defense Exhibit, page 54 of Defense Exhibit 3224. It's a sequence of emails, and I'm going to direct your attention to the one in the middle, dated November 10th, 2015 at 9:38 a.m. Anthony Kirkpatrick, MD, PhD, wrote, etc. It says it's addressed to Ms. Kowalski. Now, directing your attention to that email to Ms. Kowalski, it reads, today I received a request from pharmacist Jocelyn Krager requesting that I write a script stating that Maya is terminal. You said copy of that request is below. I am not willing to do that. It is beyond my scope of practice. And then it reads, on November 7th, 2015, I gave you what I believe is in Maya's best interest. Copy attached. Maya is 10 years old, and it's up to you as her mother to do what you believe is in her best interest. And the next paragraph goes on, I suggest you contact your local hospice care unit and determine if they have a palliative care program, and then it's signed by you. Did you send that email to Ms. Kowalski on November 10th, 2015?
I did.
And then finally, as far as we are concerned, at least, you indicated, I believe, in questioning that there was a request for records that you received regarding Maya Kowalski at or about the time you spoke with Sally Smith.
Correct.
Did that come from DCF?
I believe so. Yes.
Okay. And that's the request to which you did not respond, correct?
Well, no, we did respond with
Oh,
her.
you did respond.
As far as I know, yeah. Oh,
Okay, I
yeah.
misunderstood your testimony. Okay, so you're telling me you got a request for medical records regarding Maya Kowalski, not from Dr. Smith, but from DCF.
Correct. That's my understanding.
Okay, and you complied with that request.
To the best of my knowledge.
Okay, thank you, sir.
You're welcome.
Could I have?
Oh, sure.
I need to give these to Clerk Judge Rowe. I think we're good.
Mr. Anderson, do you have any questions?
Yes. Doctor, did it turn out that that terminal prescription was actually for the purpose of qualifying insurance requirements to qualify for coverage or hope for coverage of the ketamine and other medications for Maya?
I'm not sure of what it is, or if it's a scope of practice issue. I'm not sure. I'm not sure.
Did you ever have any conversations with Mr. Schott, who was the pharmacist who was assisting the Kowalskis in attempting to obtain insurance coverage for the medications?
I don't recall.
That's it, Your Honor.
Doctor, for the script that in your mind was not filled, can you tell me in just simple terms what that was for?
Oh, it was for Dilaudid, I believe. It's an opioid.
Was it a specific way it was to be administered?
Yeah, what we're, keep it succinct.
I'm not a doctor, so can you just...
No, sure, I understand that. This is called IVPCA. And it basically the patient, even a child, it's the safest thing you can do when when they get pain, you hit the button. The beauty of it, it's almost impossible to overdose, because if they hit it too much, they'll fall asleep and they won't hit the button anymore. So they can't, it's almost impossible to overdose. And what we're trying to do here is we're testing different things. How long should the tubing be? And what type of program should we program into the pump? And I wrote something out of what I did not want to have happen, and I stressed this whenever I was talking to them. I do not want continuous infusion of opiate, because then you defeat the benefits of having the child hit it and getting what they need for that particular pain episode.
Okay. Any further questions based on the court's question?
No, sir, Your Honor.
Mr. Anderson, any further questions based on the court's question?
What was the timing on that, Doctor? When did this occur?
I was looking at the script. It's not up right now. In terms of the time frame, this was happening, I think, just before she went to Monterey.
Was this for the trip then to make her more comfortable?
Right, and the purpose, and to answer your question, Your Honor, the idea here is that she's going to have acute pain episodes, perhaps, in traveling and this and that, and this was a way to rescue acute pain, not the CRPS pain, because opioids are relatively ineffective for that.
Okay. Mr. Hunter, anything further before we end the proffer?
It'll be addressed by some other witnesses.
So we can end the proffer at this point?
Actually, I would like the witness to identify for the record what we covered in the initial questioning regarding the tapes, the videotapes.
You can proceed.
I'm just going to show them what's been marked. But I have an extra copy. Let me just ask you. I'm handing you for identification what we'll have the clerk mark as the exhibit.
What's the defense's next exhibit number for ID?
3326.
3326.
This is 1001 3326.
No, it's just 3326.
Oh, okay. So it's 3326, and I'd ask you if this email from you to Mr. Anderson is an email which you sent with the summary of follow-up evaluations. Maya Kowalski attached.
Okay. So the first question is this an email that I sent? You have two questions. Am I correct?
Yes.
Okay.
First is, did you send that email?
The one on the top.
One.
Because I'm looking at it, I don't see where it says from.
From.
Oh, okay, the one down below. Okay.
Yes, this is one here.
Okay.
I mentioned, do you send the one marked from Anthony Kirkpatrick, MD, PhD, with your email address, sent Sunday, February 2nd, 2020, at 12:36 a.m. to Greg Anderson, al. with the Anderson firm, and just says FYI, see attached. Did you send that email with the attachment that's the second page of that exhibit?
Okay, so it's February 2nd, 2020. And this was previously introduced to me, correct?
Yes, that's what we.
Yes,
that's
yes,
what I read today.
yeah, yes, that is something that was executed, this was all executed.
Okay, you sent that with the attachment?
With the attachment. Now this, I think, I'm assuming that this is the attachment.
Yes, sir.
Okay, if it is, then
Yes, sir.
we're good.
Yeah, okay.
Okay.
Good. All right, thank you.
You're welcome.
Make sure you hand it to the clerk, please.
Just briefly, Your Honor.
Yes,
May I approach the witness?
you may.
Dr. Kirkpatrick, I'm handing you your declaration of October 8th, just a couple of days ago. There have been some statements outside the presence of the jury regarding the authenticity of your signature on this declaration. So I wanted to ask you, if you turn to the last page here, is that in fact your signature on the bottom of that declaration?
Yes.
Where were you physically when you signed this document on October 8th?
Bonefish.
Thank you.
As in like the restaurant Bonefish?
Yes, sir.
What you have?
I'm sorry. That's.
I'm just joking. It's
Yeah,
getting
yeah.
kind of late.
Thank you.
Okay, are you marking that with the clerk? Well,
We'll mark it.
Probably.
We'll mark it.
what's the plaintiff's next in the series for identification?
I think the last one we marked.
I'm asking the clerk.
I thought it was 2800 was the last one we marked, but
So it'd be 2801.
Okay, so that's for ID 2801. May the doctor leave at this point?
Yes, sir.
We end the proffer at this time?
Yes, sir.
Proffer's over. Sir, you're free to go today, but you still might have to come back. Thank you for being here.
Thank you.
Okay. Do we have any issues to address before we adjourn today?
Just one, on a break, Mr. Anderson indicated to me possibly Mr. Kowalski coming back tomorrow, and I wanted to get clarification.
No, I'm gonna give him one more day. He has a sinus infection, Your Honor, and I wanted to make sure that I didn't bring him in until we sorted that out.
So the witnesses for tomorrow have not changed?
They have not, although, no, we got Dr. Hannah first thing.
Oh, okay, okay.
and so
He was supposed to go.
Yeah, understood.
if we're talking about timing tomorrow morning next, I wanted to mention that we filed a motion for reconsideration regarding admission of trial exhibit 2123-610. We'd like to take that up in the morning. This is
Can you identify what that is?
It's the BD email that was previously excluded.
Could be a long list.
How much, I guess we need to go, how much time do we need before the jury? Given whatever exhibit issues that we're gonna have, and hopefully we won't take as long as we did today. Hopefully.
Well, Your Honor, our staff has been going through the risk management notes as we've been sitting here, and the Sally Smith handwritten notes to identify the specific pages. I expect those to be in the hundreds of pages that we believe are relevant. So the question will be, how many are stipulated to, if any? So I think we need more time than usual tomorrow morning is the answer.
Can I ask, do you need those in for tomorrow?
Potentially. It sounds like with Dr. Hannah getting backed up, we might not get to Dr. Corcoran. But if we were to get to Dr. Corcoran, they may be relevant to his testimony.
Okay, I was just asking to see whether or not they had to be dealt with first thing in the morning or not.
I mean, we could have a working lunch if the court so inclined.
Well, I do have a meeting with the chief judge at 11:30 tomorrow, but after that, I'm happy to, have longer discussions, but we have a hard stop at 11:25.
I'd prefer to just get here at 8:15 for once, or 8:45 and not have to
Well, I will tell you, Thursday, the earliest we can start is 8:45. So you're going to get that wish on Thursday. So it's just about tomorrow.
Let me
Well,
ask you.
I was thinking more what time you want council here.
Yeah, would it be okay if we start at 8:30 tomorrow as
Yeah.
opposed to 8:15?
Yeah, right.
And then use some lunch time to address exhibits to the extent not covered in the morning.
Yes, we will do that.
Shot
So-
clock, Your Honor.
I'll get that in just a second. But so tomorrow, 8:30, Mr. Altenburn, you,
I only have a timing question on directed verdicts. I was worried they might actually take place on Friday, but it's beginning to look to me like they're not gonna rest until after the weekend. And getting ready for motions for directed verdict is something I gotta figure out when I'm doing, so. That's all.
Well, you're right. I mean, we are slower than we expected. I'm having to cut witnesses. I've tried to combine them. That hasn't worked too well so far. The answer to your question is likely we will wait until Monday to rest.
and what we can always do is just kind of agree that if, let's say you did finish on Friday, we could just agree to do it at some future time.
That's possible too.
Yeah. Okay, so the shot clock is for today, plan is 2 hours, 55 minutes for a cumulative running total of 32 hours, 55 minutes. Defense had 1 hour, 20 minutes for a running total of 12 hours, 10 minutes. With that, anything else, or are we good to go for today?
We're good to go.
Have a great day, everybody. We'll see you tomorrow, 8:30.